Hey, Alan.
Hey, Craig. How you doing?
Welcome back.
Thank you.
How's everything?
Great.
How was your ride over the ferry today?
Beautiful. I always pass the lab, and I think to myself...
we used to be in there. You had a long career in there.
Yeah, we used to go. We were there so many hours.
Oh, my God. I just was driving back not that long ago to get some car work done, and we went past there, and I saw the lab, and Dina and I were like, oh, my God, remember that?
I remember those 4 o'clock in the mornings waiting for McDonald's to open so we can get some coffee.
Exactly. That was good times. Two kidney guys in the flow state here, talking about kidney stuff, and you can see the long list of things we've talked about. And today we have, I think, one of the most interesting and relevant topics to recent findings and things going on. So what are we talking about today, Alan? Give us an update.
Well, I've been happy to see that, we didn't really pick this order explicitly, but it turned out to be working out for us. And so, we did I just wondered if you recovered fully from the 3-hour and 15-minute blood pressure talk.
Oh my God, that blood pressure talk was massive.
Yeah.
That was a purge, but I'm so glad we did it in one big block.
Yeah.
Because we had a lot of momentum and there was a lot to learn in that talk. It was awesome.
Right. So this talk today is...
How far back are you going to start?
Not ancient China. So it turns out that this talk pretty much starts in the 1920s.
Interesting.
So today we're going to talk about, and again, this is very important for our patients with kidney disease. We're going to talk about phosphate, parathyroid hormone, FGF23, Klotho, chronic kidney disease, and aging. It all comes together amazingly.
Yeah, and I think this is even important. When I review this stuff, to me, these issues with phosphorus pertain to everybody. Even with normal GFRs. So I think this talk has some benefit to everybody.
Yeah, and you've given yourself a bunch of talks over the years on this topic.
I'm a Wolfian.
Yeah. Well, and in preparing for this, I think you even had a chance to talk to Miles.
Yes,
Wolf.
I did. I sent a little email. He was kind enough. Yes, he was. Yep, we graduated together. He was the curve buster. He's just a brilliant guy, and he loves physiology. And he's just reminds me of other people I know.
Well, it's great that we have those connections where we can take a topic like this, and he's a major player because FGF23 is a major player.
Yeah,
and his work, of course, is very important and has taught us a lot. There was, as I'll go over, there was no FGF23 when I was a medical student or a resident or a fellow.
Yeah, yeah. And I think, no, that's interesting. I'm psyched for this one. This is going to be great.
But I mean, the way that kind of the unexpected, at first, that mineral, we call it CKD MBD, the mineral bone disease of chronic kidney disease, because it got too confusing just naming it what we're talking about.
Right.
And it's just interesting that the intersection of that with aging might have been unexpected, but then but once you find out and look at it, it makes a little bit more sense.
Right. I mean, for so long it was called renal osteodystrophy because everybody thought this was all about bone. Right. And even though bone's a centerpiece of it, it missed the most important thing, that this process probably is the reason people with kidney disease die younger.
It's true. And, the names like osteitis fibrosis cystica, that was coined in the 30s.
Right.
So, these are old names.
Yeah.
And we'll talk a little bit about that.
No, it's awesome.
Yeah. So,
let's dig in.
Ready to dig in?
I'm ready.
Okay. So today's talk, as I said, phosphate, PTH, vitamin D, FGF23, Klotho, CKD and Aging. And here's a review from 2019 by a very important person in the field. And I think, one of the things that confuses people since the beginning, and when medical students first learn about this, is, there's these multiple loops, unlike some of the other things that are more straightforward. There's a number of organs involved with this. So we're talking about not only the gut where we take our phosphate in, but also the interaction between parathyroid gland, bone, and kidney. So these are, and again, you've got these multiple feedback loops where, something stimulating something feeding back negatively on it. We'll talk more about this. But, the question is always where to start.
Right.
Because these are circles, and sometimes in a circle, you got to know where to start. And so one reasonable place to start is with phosphate intake. And, it's still unknown. We've talked about the calcium sensing receptor, and there's no doubt about, that's all over the parathyroid and all over the kidney. It keeps track of calcium on both sides of the membrane, so that we got the calcium sensing receptor on the basolateral membrane of the thick ascending loop sensing blood calcium, and then we've got the calcium sensing receptors in the apical membrane of the more distal nephron, making sure that there's enough water in the nephron to not have stone formation. So the same, nature went to a lot of trouble to make that calcium sensing receptor
reusable in different situations.
Put it in a lot of different places, and we always wanted to say, like, well, what's the phosphate sensing receptor?
Right.
I mean, is it possible that there's a separate phosphate sensing receptor that we haven't discovered yet? Is it possible that the calcium sensing receptor somehow plays a role in that? Because it's, it doesn't. These things can be multifunctional proteins.
And I would just add, like, for all the years that I've given this talk, one of my final slide was always on the gaps of knowledge.
Yeah.
One of the big ones was, what's sensing phosphorus? How does this happen?
Yeah. So people have always talked about, giving it names like phosphatonin. What is the phosphatonin?
Yeah.
And where is the sensing happening? And so, one thing that people have talked about is these calci-protein particle colloids of calcium and phosphate bound to phytoin A. And, if that's true, these have to be sent somewhere. But, like everything else, the homeostasis steady state rule that we excrete what we eat, phosphate is brought in to the body, it's absorbed in the gut, and the kidney excretes it, and there has to be some steady state.
Right.
So, here's the major players outlined, but we'll talk about each of them in detail because it is confusing. So I wanted to start off with the back in my day. So back in my day, which was the mid-'80s and mid-'90s of my training, there was really, people talked about calcium, phosphate, PTH, and vitamin D. There really weren't, those were the major players. And we learned, fairly straightforward, that PTH increased extracellular calcium by action on bone and kidney, and also acted to promote the excretion of phosphate in the urine. So everybody's, well, PTH is interesting because it seems to be very concerned with calcium metabolism, and because PTH is phosphaturic in the sense that it tells the kidney to not reabsorb the phosphate, it looks like maybe regulating phosphate as well. So is PTH the controller because it seems to have a hand in both calcium and phosphate. And we knew about the negative feedback system between ECF calcium and PTH, but the molecular mechanism wasn't known. So we said, okay, there is this feedback going on, the negative feedback, but what's the sensor?
Right.
And it wasn't until the mid-1990s when Ed Brown and Steve Hebert cloned the calcium sensing receptor that we started to get real insights to that. And this very quickly translated into therapy, because even though it was the mid-1990s when the calcium sensing receptor was cloned, it was the New England Journal paper, I think in 2000, not very many years later, showing the potential of calcium mimetics like cinacalcet for treating primary hyperparathyroidism. And of course, then we were early adopters of that in nephrology.
And then there was a huge paradigm shift at that point to start not using calcium base binders, because it was just before that when like Renagel came out and these initial kind of non-calcium based binders that were giving people too much calcium also.
Well, the phosphate binders have always been problematic. And the reason they've been problematic, they've never been easy to take.
Yeah.
And they have to take them all the time, every time they eat. I mean, so a lot of times we tell our patients, if you're eating something, you got to be phosphate binding it.
Right.
And, that goes for snacks too. So a lot of patients will just take it at meals because the bottle says take with meals, but you got to take it with food. Every time you're eating. If you're swallowing phosphate, you need a binder. And these binders were problematic from the beginning. The first binders when I was training was still the aluminum-based binders.
Right, exactly.
And
Amphigel.
And Amphigel. And, that was about the time in the 80s that people were concerned about, the aluminum leading to encephalopathy.
Right, dementia.
There was aluminum, and our dialysis patients are exposed to a lot of aluminum because you've got the aluminum in the phosphate binders, and then you've got the aluminum in the dialysate.
Right.
Now we test for that.
Right.
So the cloning of the calcium sensing receptor led to a real revolution in understanding physiology at a deeper level, evolutionary physiology at a deeper level, and also now the calcium mimetics. Cinacalcet was the first one to come out, the oral one. We'll talk about that, and now we have an IV one. And these are obviously very big in the, they got incorporated into the bundle.
Right. That was big.
It's big. So this, like I said, paved the way for the calciumetic therapy of hyper-PTH. We also knew about vitamin D, that the kidney played a major role in activating vitamin D. It turned 25 hydroxy vitamin D3 into the active form 125 hydroxy vitamin D3 by this hydroxylase in the kidney, proximal tubule. And this vitamin D promoted, again, became a little bit good but confusing because it was gut calcium and phosphate that was, you really want to have both of those come in? Is that a good idea? Obviously, that's what nature wants to do, but it wasn't good if your kidney didn't work.
Right.
And so it became difficult because we wanted to give people vitamin D because we didn't want hypocalcemia, but then it would bring with it gut reabsorption of phosphate. Okay, and that was not good for the bone. So as CKD progresses, we learned that, now you're going to have decreased conversion of the active vitamin D. That could lead to the hypocalcemia. That's part of the hypocalcemia, and hyperphosphatemia. And now that's going to stimulate, both of those are going to stimulate PTH, and the natural, it's again the balloon, you squeeze it in one place.
Right, and expands on the other.
Right, and so both of those were going to point to PTH. And then all of a sudden we became concerned about hyper-PTH levels, hyper-PTHemia, as a cause of bone disease, and we started aggressively treating
a high parathyroid level.
But what was missing was data that showed that that doing that was giving some sort of benefit.
Yeah.
So treatment with oral phosphate binders and vitamin D supplements made sense, but was hampered by the side effects of hard to take and the other things. It wasn't ideal. We knew it wasn't ideal. We were chasing our tail a bit. And
so when was Slatopolsky again? Because he was one of the original PTH guys, right?
Right. So, when I interviewed for a fellowship, one of the places I interviewed was, I was in Chicago, so it was an easy trip to St. Louis,
right,
to WashU. And WashU was famous then and still now as being the place for the mineral bone fellowship. So I was interested, if I was, that would have been a place I would have been high on my list. I mean, I loved EPhys and channels, so I went to Yale and then my transport. But clearly the visit to WashU, meeting all the famous people there, Salu Clark, Kevin Martin, Aubrey Morrissey, Eduardo Slatopolsky, this was the center of PTH.
Right. Secondary hyperparathyroidism.
Yeah, and of course that's also important for stones. And having been trained by Fred Coe in Chicago with stones, it was these people knew each other pretty well. But then the party line was it was all PTH,
right.
And so Slatopolsky's work, which was huge, paved the way for paracalcitol and other drugs that we were using because it was a translational research. You had these physiological studies leading to pharmaceutical actions. So that was really the center of the field. But problem was there's other players that we now know about, including Miles Wolff and FGF23, that had yet to be discovered. So let me just sort of take you, where are we now? So here is the problem with the field. And
too many arrows?
Yeah, I mean, I got to say, I wouldn't expect anybody to understand this diagram.
Every time I look at a diagram that outlines what's happening, number one, I never know where to start.
You never know where to start.
Because there's no start line.
Right.
There's just these interactions, and all you get are plus and minus feedbacks on what's impacting what.
Right. What I take away from this hypoera diagramemia is that whatever it is, it's very complex.
True.
And whatever it is, it's confusing.
It is. And anytime I look at one of these, I always think of a condition. Of course, for us, it's chronic kidney disease. And I think, okay, well, their ability to excrete phosphorus is down.
Yeah.
Their serum blood phosphorus is going to go up. And so I always look at these starting from phosphorus. And I say, all right, well, if the phosphorus goes up, that's going to cause, in this particular picture, FGF23 to go up, and then that's going to lead to the kidney to get rid of phosphorus. So I always start there because it's a place to start.
Well, I think that's a good point that you're making, and the reason it's kind of funny is because I think we all do that because this is the diagram when the kidney works,
right?
Let alone what happens when the kidney stops working.
Right. But that's probably the same thing. You have phosphorus goes up, you get a phosphorus load, there's some trigger, right. FGF23 goes up, and then it causes the kidney to excrete phosphorus.
Well, one of the things that helped me actually was, during early medical school, learning about the physiology, things, it was easiest to start with calcium conceptually, calcium PTH axis. One of the things I learned when I did a 4th year rotation with Fred Coe, who, Fred Coe is, we may have mentioned this before. He's a Renaissance genius.
Oh my God.
And Fred is just the sweetest guy. And he has a website, UChicago, I think it's like UChicago kidney book. He's got an online living textbook of everything stones.
That's amazing.
And he doesn't just talk about stones. He talks about interaction with art. He looks for paintings where people might have had kidney stones.
That's so awesome.
He's just, in terms of, his website is a delight because not only do you learn, from a genius of chemistry and a genius of stones, but the way he integrates art and culture. Every page has a different painting on it.
So beautiful.
Music. It is beautiful, and I highly recommend it. I go there all the time, and I think I may have mentioned Fred, people, when I say people, I mean the public, send him questions on that website.
Wow.
And he personally answers them.
That's amazing.
So he'll post the question without the person's name, like, I'm doing this, I'm eating this, and what do you recommend? Or my stone showed this. And of course, it was Fred who started Litholink in Chicago.
Right.
And everybody knows, every nephrologist knows Litholink.
Absolutely.
What they may not know.
It's a very important tool for us.
What they may not know is that Fred was the founder and became a kind of a family business. And, he, working with younger folks, made it easier because, he coordinated with FedEx and, how to transport the 24-hour urines, and then gave this beautiful chemical analysis, which was not just the numbers, but plotted them in a way where you see, okay, this number makes you more likely to form stones.
Exactly.
This makes you less. So, Fred, I can't say enough great things about him. I was very lucky to meet him when I was a student because he taught us first year physiology, and it was just fantastic.
That's amazing.
He did a review session once, and I learned an important lesson from him. So everybody's, all the students were worrying about the test, and kidney was not easy for a lot of people, for nobody.
Right.
And so Fred had an evening review session. So we all met at the big P117.
At the co-home.
We met at P117, which was the big auditorium.
All right.
P117 had it. We used to make fun of P117 because it used to have, it was a big room with the slanted stairs, seats. And we used to joke about it because the room was so big that the weather in the room was different depending on where you were staying.
Oh, that's
so
funny.
In our senior skit we did a weather report, the P117 weather report. So we have a heat wave coming in on the seats in the front,
that's so
and there's a cold front moving into the back row.
That's great.
We said the students, the Stains who were sitting in the front row, and the crossword puzzle coffee drinkers in the back. Were getting an iced coffee because a cold front was coming in at the back.
That's classic.
So he called us in for a review session, and again, that was before there was internet, and we had to go to the library, and so you couldn't miss it. You had to be there. There was no Zoom, and I wondered, how is Fred, of course Dr. Coe at that time,
right?
Well, I was delighted the day he told me, call me Fred,
right.
And I said, how is he going to handle this review session? Because we're all got lots of questions, and there's all these interacting things, the acid base and the potassium and the whatnot. And he, of course, being Fred, came in and he said, okay, here's what we're going to do. We're going to start with one word. And I said, okay, this is going to be good. So he says, vomiting. This was before Jerry Maguire. I go, you had me at vomiting.
Right, exactly.
You had me at vomiting. And he showed how you take a very common thing,
right?
Everybody's got experience with vomiting, and shows how he could tie in and integrate the physiology of volume status, water status,
acid base,
and potassium, all by starting with vomiting.
Right.
And this became really the way to understand. There's chapters on all these things, but really, as we've tried to do in these podcasts,
how do you put it all together?
Yeah, vomiting is one thing.
Yeah.
And it sets off all these different loops. And so that was extremely, I said, what a genius. He showed us by using integrated physiology of something that patients complain of, a very common clinical problem, how to basically integrate our knowledge.
Right.
And it was very helpful. And I've used it myself. Of course, when I've had review sessions, I'll say well, let's, I've lectured on all these things and you've done work on it, but let's look at vomiting. So a diagram like this tells me that, but the other thing that I was going to mention that Fred showed me when I was a fourth year student rotating with him was like you, he also decided that it would be helpful to start not with PTH calcium, and he started with phosphate. And again, I think that's a little bit of a nephrology bias because, our CKD patients have phosphate issues that lead to parathyroid issues and whatnot. And so even though calcium is involved, it's not like our CKD patients have they have normal calcemia for the most part.
It was funny because just as I finished fellowship in 2002, and the first KDOQI guidelines came out, I took their algorithms for calcium, phosphorus, and PTH and vitamin D. And they were 3 separate algorithms, but they were ambiguous in that one would tell you to do something like, add calcium, and the other would tell you not to, or add rocaltrol, and the other would say hold rocaltrol. Right. So they were so I decided to integrate them and code them all together in very simplistic, not AI, but in simplistic rule-based system.
Yeah.
That was very detailed. And the one thing, I did it so many different ways, but the only way that worked was starting with phosphorus. And then I had it go down these different trees where it was started with phosphorus, then it would look at calcium, then it would look at PTH and tell you what to do in different settings.
That's very interesting because two things about that. One is, as you point out, these separate algorithms were contradictory.
Exactly.
And another thing I know that you learned
in the lab,
you learned while you were a fellow, was one of the most well-known in terms of clinical importance that came out of UVM was the SOAP note that came out from Larry Weed.
Exactly.
And I remember being in Chicago and not knowing anything about Vermont, but I got interested in this, the SOAP note. And found out, of course, when I read up on it, that it was kind of a thing that started with Larry.
Right.
And wanted to do an away rotation with him specifically for that, because it seemed to integrate the clinical medicine note with my kind of the things appealed about engineering, but organizing these things like you're talking about.
Exactly.
So you spent some time with him learning about couplers.
He had his problem knowledge couplers, and I brought and presented my anemia algorithms, computerized anemia algorithms, because I was taking all the KDOQI guidelines and I'm like, these need to be coded.
Right.
Like, this is numbers. These are under the hood. Patients are complaining. Yeah. This is number crunching and analysis. And I said, this is perfect for a computer-based system. And I brought it to him. But they were really working on big things like depression analysis, all these big screening.
Well, for people who don't know what knowledge couplers are, what are they?
So the knowledge couplers are, you fill out a questionnaire. It's just a series of questions, and it's with a basic diagnosis like hyponatremia or depression. And you would go through a series of questions, and this thing, it was a combinatorial approach to finding out what the diagnosis was. And it was impressive. And he showed me the example he gave me when I met with him, and it was an awesome meeting. I learned so much. And then he tapped me on the shoulder and he said, Craig, go be a nephrologist. He was like, I think he wasn't really interested in dialysis, although his wife was a dialysis patient, not ours, but she had severe lupus and she was a kidney patient for many years. And he's a super nice guy. He was a super nice guy.
So what was the example that he used?
So the example he gave me was a patient, a young girl with fatigue and hyperkalemia. And it was a New England Journal, and the New England Journal case went through it, and it took them 6 months, and finally after 6 months they diagnosed adrenal insufficiency.
Wow.
And he plugs in the first paragraph.
Shouldn't take 6 months.
He plugs in the first paragraph in the problem knowledge coupler, and it's like, most likely diagnosis, adrenal insufficiency.
And that was kind of hand AI.
Exactly. It was amazing.
Manual AI.
And he did it with IDX, the computer company who was working with them.
Right.
But it was really fascinating. I learned a lot. And it makes me think of these things. When people talk to me about rare diseases or other things, I'm like, that's rare unless you have all these things line up And then if you have all these conditions, it's actually the most likely diagnosis.
Well, it reminds me again of what I've talked about before here is my 7th grade LEAF project, where you had the book, and the book just asks you, branch questions. Is this a pin, a needle from a tree, or is this a leaf?
Right.
And if it's a leaf, are the veins parallel or they alternate? And basically the book, just said, we're going to get you to the identification of the leaf if you just keep answering the bracketology.
Right.
And that's kind of knowledge couplers.
Yes, that's exactly knowledge couplers.
You have the input, which are the answers to these questions, and then the algorithm, whether it's hand done or AI done, that basically says, look, I don't care how rare the disorder is. It's a line item, just like the common ones.
Right.
And I'll just use the input to say, hey, it just turns out that this rare thing is more likely.
Right.
Because
goes to the top of the list.
Right, because our bias is that rare things are rare.
Right.
And they always say, uncommon presentations of common things are more common than common presentations of uncommon things.
Right.
But there's no bias or less bias if you're just going like, here's where the algorithm took me.
Right.
And so I think you did learn, and that's very good. And that's why you then went beyond that and did the algorithms that you just told me about to deal with. You said, okay, now I got this. These two things are telling me two different things to do. Let me take the bias out. Let me run the thing and start with phosphate.
Right. And that worked very well. And we got a grant for that with this computer company, a dialysis EMR company, where we wired it into the system.
Right.
But it was funny because when I went there for the meeting with them, they basically felt that, everybody agreed that phosphorus was the place to start, because we were all talking about where do we start. Right. And there were a number of other interesting people in there. And it was phosphorus. Definitely, everybody agreed that was the place to start.
But when you determined that, what was your interpretation then and now about why? What does it tell us that when you had to do this, it was phosphorus that was the thing to start with? What does that tell us?
At that time, that was one of the. It's a late marker, but it was the thing we looked at, and we were dealing mostly with dialysis patients. And of course, the company I was working with was a dialysis EMR company. But I think the point is that phosphorus seemed to be the most important thing that we all thought was central to it. Although PTH is just as important, at that time, those were the big ones. This was like 2006.
Was it just as FGF23 was coming in?
Right, just as we were learning about FGF23. Right. And for a long time, I was writing the software thinking there's another, and as Miles' stuff was coming out with mortality and really important studies, I was like, okay, we're missing the most important variable here.
Right, so again, we talk about the anion gap being the unmeasured anions. What about the unmeasured knowledge?
Yes.
Okay, and so that's the knowledge gap. Right. And you had a sense, and we all kind of had a sense, that if things are going to be this complicated, there's probably some stuff we're not knowing. And it could be, I don't know if this is going to end up being true, but maybe one of the reasons phosphorus came out for you as the place to start was because all of a sudden, even though we didn't maybe know it, the algorithms were detecting a subtle change in phosphate transport, which might come up later in this talk. I have a feeling it's going to come up. So what were the key issues and questions during my training period, your training period, and even today? So patients with chronic kidney disease and hyperphosphatemia are consistently shown to have decreased survival. And this is our classic true, and related, or true, and unrelated. Is this cause and effect, or is this an association? So, the first thing is, okay, dialysis patients have high phosphate, they die faster. Well, then all we have to do is prevent the phosphate from getting high. And the disappointing thing was on the individual patient level, controlling their phosphorus to lower numbers didn't seem to translate so well into better survival. So the first question was, does decreasing the individual patient's phosphate level actually improve their survival, or do they need something else? Another question that comes up is, does the form in which we eat phosphate matter? We'll talk about that. So those are some questions. Another set of questions is, exactly how do high phosphate levels decrease survival? Right. Is it phosphate metabolism, or is it the calcification, an ossification of blood vessels?
Or maybe they don't decrease survival. They're correlated with decreased survival.
Right. And that's the thing. Is it cause and effect?
Right.
And so why? So again, we still wonder, why is calcium phosphate homeostasis so complex? Why does activated vitamin D promote the absorption of both calcium phosphate from the gut? Is that a good idea? Yes, but is it a good idea when the kidney's not working?
Right.
Again, a lot of good ideas when the kidney's in the game turn out to be bad ideas. I mean, drinking water is a great idea.
And I think that's a very important question that I think now is getting some answers to.
Right. So now that we know about PTH and FGF23, one of the first things that came out to confuse us is we got this new player, but both of them were phosphaturic. I mean, one way to remember PTH is PT, phosphaturic.
Right.
But FGF23 also is phosphaturic, and they both do it by inhibiting the same transporter. Why are there two arrows going to this from two different hormones?
Right.
Now, FGF23 differs from PTH. PTH stimulates 1-alpha hydroxylase conversion to the activated vitamin D3. FGF23 has the opposite effect. So there's a yin-yang there.
Yeah.
And so this is exciting because it's like, okay, let's work this out. So, as I mentioned, we start it wasn't until really the 1920s was one of the heydays for endocrine, because it was about 100 years ago that Best and Banting came up with insulin, and that became obviously revolutionary for the treatment of diabetes. And one of the heroes for me, not only a hero before what he did, but one of the greatest names in history, Fuller Albright.
I love it.
So Fuller Albright, he was already using parathyroid hormone in the very early days. Here's a 1929 JCI paper of his, studies on the physiology of the parathyroid glands. I mean, this guy is like doing it. And he comes up with all sorts. He comes up with the relation to the bone disease. He coins, I think he coined osteitis fibrosis cystica.
That's amazing.
So here's just a paper I took from 1938. And the reason it's important is, 1938 is 50 years before I started my fellowship.
Right.
And in the 50 years since 1938,
the damn table looks the same. No, I'm just kidding.
So Fuller,
he was onto something.
He was
for sure.
So Fuller Albright, a very genius guy, and he was, he lived in this time. So he was only, less than 30 years old when he was all of a sudden starting to look at PTH, and PTH is going to lead him right to calcium, and that's going to lead him to phosphate. So I think in this paper, he says the last line of the paper, they didn't have Photoshop and Adobe Illustrator and PowerPoint.
Oh yeah.
So,
but this is still better than that nephron I saw, John, in our first.
Nephron,
oh my God, the angry nephron. This is way better.
So he says in his paper, and you got to love the guy for saying this. Below is an attempt to present you some diagram, because he even said this is confusing, man.
Yeah.
So he starts with vitamin D, and because the name of the paper is the effect of vitamin D on calcium and phosphorus. And he starts with vitamin D and immediately says, okay, what do you look at first? So the Roman numerals here are what to look at first. So the first thing is it decreases fecal calcium, okay? And therefore, and the reason it decreases fecal calcium
increases reabsorption.
Right, so the serum calcium has gone up, and that's number 2.
Right.
And then the number 3 all of a sudden splits out into this 3 prongs. First of all, you've got a bone effect, and that bone effect gives you some sort of a phosphate effect. And then it's affecting the parathyroid, because both of these things he says, okay, these things all seem to impact the parathyroid gland. It's affecting the disposal of calcium, and it's affecting the disposal of phosphate. So he says it right here.
Right.
It's vitamin D has these effects on calcium and phosphorus. And he also says, look, the urine phosphate goes up. So there's a phosphaturic effect. Is that vitamin D, or is that parathyroid hormone? Well, we find out later it's parathyroid hormone. So this is his understanding of it in 1938. And the thing about it is, that was my understanding of it in 1988. Nothing changed significantly, because the players of vitamin D, PTH, calcium, and phosphate were the 4 players. And the parathyroid, bone, and gut were already the organs. And that stayed that way until FGF23, the calcium sensing receptor, and that was all after 1988. So 50 years, this is the thing. It just shows, the guy was onto it, man. And he did tremendous work.
It's amazing.
I love that. So let's just start by talking about the effects of these individual hormones before we try to put it all together. So I always like to start with the sun. That's pretty much.
It's the truth from the allegory of the cave. I think it's a great place to start because it starts you out of the cave.
Starts you out of the cave, the real sun.
That is it.
So in olden timey days, we got all the vitamin D we needed from the sun. So the UV, ultraviolet B rays from the sun convert something called 7-dihydrocholesterol to vitamin D3. And it turned out that in places where people were getting reasonable sun, you really only needed 15 minutes a day of sun exposure to the skin. And you would wonder, well, the people are getting a lot more than that, right? Because they're not shielded from the sun. We didn't have sunblock. But it turns out that nature had already figured out a way to avoid vitamin D toxicity. It's impossible to get vitamin D toxicity from the sun, because what happens is once you have enough vitamin D formed, the other sterols are made which do not have the calcium effect of vitamin D. So they might have other important things to do, but you can stay in the sun for more than 15 minutes. Now, the sun exposure is bad for skin cancer.
Right.
But then when we started becoming industrial, big buildings plus smog, in England, where it's cloudy and there's buildings and there's smog, there's all of a sudden there's going to be all this rickets came out because people couldn't get their vitamin D. And the diet wasn't great. It's the sun that you need, let's face it. The diet, there was some great stuff. Cod liver oil is probably the best way to get D from the diet. Trout, oily fish. They're the main sources of dietary D. And this launched the revolution of vitamin D supplement, fortification, they call it. Fortification of vitamin D to milk and stuff like that. So we all said, we'll drink enough milk. But now that we still have big buildings and smog and sunscreen, the whole world's vitamin D deficient.
Right.
Now vitamin D's got multiple effects we'll talk about. But even though that vitamin D deficiency is very, 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 very common, especially up here in the North Country.
And the question is, could that have something to do with how our diets have changed in terms of the phosphorus loads, where phosphorus is used in so much fast foods that's driving this inhibitory process? Exactly.
So now, of course, because they called it vitamin D, I think what's unfortunate, if it would have always been called calcitriol or cholecalciferol, I don't think people would get on the bandwagon so much, because anything called a vitamin, people tend to interpret as all good.
Right.
But you can get hypervitaminosis A from eating too much, liver. That's described. You can get too much vitamin C that causes kidney stones, people that megadose on vitamin C. Mm-hmm. And, if you're megadosing on vitamin C and vitamin D, first of all, it's not clear how that's affecting whether it's solving the problem, but it's certainly causing a lot of problems with bone and kidney stone, and we've seen this. So I'm not a big proponent of huge doses of vitamin D. I'm not a big proponent of mega doses of anything. It's not Goldilocks.
Right.
But I'm pretty sure if vitamin C would have just been called ascorbic acid and vitamin D would have just been called cholecalciferol, we'd have a lot less controversies about this. But, that's not to say that these substances don't do a lot, but, it's not enough. It's not, you eat carrots. When my eyes were getting bad as a kid, I said, I'll just eat carrots. And, they said that's good for you. And you can eat all the carrots you want. You're still going to need glasses. So calcitriol gets activated by the 1-alpha hydroxylase in the kidney, and the PTH stimulates the 1-alpha hydroxylase. Right. Calcitriol itself has multiple effects, as we mentioned, in the gut, and because of what Fuller Albright told us, calcium and phosphate absorption. It plays an important role in cardiovascular health and immune health, and that's why it's become so controversial in the pandemic. The people that say, okay, up your vitamin D.
Right.
And the problem is the science doesn't show that mega doses of vitamins are helpful. It just doesn't. And it shows that there's harm. So
did they show anything with vitamin D deficiency making you more at risk? Not necessarily.
Well, you have a pandemic where everybody's getting it.
And they're vitamin D deficient.
But again, what would the coupler say?
Right, there you go.
So the question is it easy to find people that have COVID and also have vitamin D deficiency? Yes,
it seems like they're getting sick in Florida, and they're probably not as well. Maybe they are, though, because it could be dietary and not related to the sun. So
right, but if there's more cases in a place where there's a lot of sun, than there are in places where there aren't a lot of sun. So Florida versus the North Country, that sort of goes against it.
Right,
it sort of goes more for the association.
No, exactly. That's
it's lifestyle. If you don't go outside, and during the pandemic, We didn't go outside.
Right.
And sunlight through windows, the UVB is blocked by the window. So sometimes you think, well, the sun's coming through the window.
Right.
You're not getting your vitamin D that way.
Right.
Okay. So there's other regulars of calcitriol, as we mentioned. FGF23 inhibits the 1-alpha hydroxylase that PTH stimulates.
Right.
So again, PTH stimulates 1-alpha. FGS inhibits 1-alpha. So there's a yin-yang.
Yeah, and that was one of the ways I put that together as I've reviewed this.
Right.
Yep.
So that's calcitriol. And again, there's a million names for vitamin D.
Right.
There's ergocalciferol is vitamin D2.
D2. That's the one that's in the guidelines recommended.
Right. So even when you're supplementing people's vitamin D, we give the dialysis folks or the CKD folks D3.
Right.
And that D3 is calcitriol.
Right.
The stuff that the kidney would have made if it could. Whereas a lot of the vitamin D in medicine patients is ergo.
Right. D2.
So there's all these long names, and they all got vitamin D. I think it hasn't helped the field that there's 15 names for the same thing.
Right.
So here's 3 names for the same thing right on the top of the slide. 3 names for the same thing.
Right.
And then there's Rocaltrol, which is another name for the same thing.
Right.
So people are confused.
Of course.
And the pharmacy gets confused because people end up writing the wrong prescription, or the pharmacy says, this really should be this. And then the doses are all over the place.
Right.
So again, here's a review of that from pediatric nephrology, which I like, because, the real disease was in, when they started noticing that with smog in the buildings that the kids were getting rickets. It was vitamin D dependent rickets. So here again is the sun causing UVB, 7-dehydroxy cholesterol gets converted to D3. And then again, there's the fish and some other things. But then the liver turns it into 25. And then the kidney 1-alpha hydroxylates that to 125. And the 125 of the calcitriol is the active thing. And then you got this mess.
Right.
And what does the mess show? Bone, and then outside of bone is also osteoclasts are in bone.
Right.
This picture shows, the liver, the gut, the parathyroid, the kidney.
Are those circulating osteocytes?
So but it's trying to incorporate.
Yeah.
And we got more arrows.
Right.
So I think this is great, but where do you start?
Yeah.
You start at the sun, great. Then it gets complicated real fast. Once you get down to everything looks great till you get to the kidney, and then you get all this. And it's like, what's driving what? So one of the things that turns out to be useful to look at is as you get decreased kidney function, what happens to these hormones? So in this particular curve, which is representative of a lot of things you can find in literature, it turns out that one of the early things that happens as EGFR decreases, as FGF23 levels go out, and it may be the earliest alteration in mineral metabolism.
And that was an email I had with Miles where I asked him just some quick questions. The guy's busy, but he was so nice to answer me back. And he was like, yes, this is the earliest. He believes, in his opinion, based on everything he sees, this is the earliest alteration in mineral metabolism.
Right. And this figure, which I don't think is taken from one of his papers, I don't remember the authors, but he may be on this. But anyway, FGF23 is very early. It's certainly earlier than we start to see a fall in vitamin D. And you can see that progresses. And the FGF23 goes up, and the vitamin D goes down, and the PTH goes up. So again, we have both of these going up, which are both phosphaturic.
Right.
But having opposite effects on the 1-alpha hydroxylase, even if the 1-alpha hydroxylase is still there. So first of all, you got CKD destroying the 1-alpha hydroxylase, the decreased functioning kidney mass. And then you got these two hormones fighting it out. It's like I put a humidifier and a dehumidifier in my basement. Let them fight it out.
Right.
Okay. So and then the kind of the last thing, the tail, is the phosphate, and this is the thing
that they recommend we focus on and we treat. By then, the cat is out of the bag.
Oh yeah. Well, no, and also the horse is out of the barn.
Right. GFR less than 30.
So you got cats and horses running everywhere. And the thing is that this is what we see on the BMP. See, the BMP doesn't give you these. So first of all, FGF23 levels are new. They're still figuring out the best way to measure them. Vitamin D measurements are notoriously not reliable PTH levels, again, during my training, is which part of the PTH did we measure? The assay was, level depends on your assay. And
I think we're seeing that same question with FGF23 now, is because there's multiple assays there.
Right. So the thing that people hung their hats on was, the measurement of phosphate was an easier measurement compared to all these.
Right.
And so once that starts going up, there's two things that's true. It's the easiest measurement to make, but it's the latest. And then and targeting therapy toward that doesn't guarantee. It's a reasonable hypothesis,
right,
but doesn't guarantee that's going to fix the problem. And I think that subsequent studies have shown it didn't. Okay?
Right. And by then, the other issues going on, the adaptations that are happening before this maladaptation is leading to all these negative effects on the vascular system.
Right.
And so that is the key, because if you look at this graph, the heart disease, the cardiovascular risk all goes up at 60 when you get below, when you start hitting 3A and 3B.
Right. And so if you had ossification of the cardiovascular system, does decreasing the phosphate, is that reversible? That all of a sudden your ossification goes back? I mean, ossification may be difficult to get rid of once it's there.
Right.
So it was always like, when should you start the TUMs or the phosphate binders? Do you wait for phosphorus to go up? Do you anticipate that it's going to? Do you help people get into the habit of learning how to take phosphate binders when they eat? A lot of counterpoint can be said about
this. Is a really great slide.
So yeah, and so it's only from 5-6 years ago.
Yeah.
So here I want to get back and call back our negative feedback systems, the way nature controls a lot of stuff. And positive feedback is useful when you're trying to explode something out of the body, like you're trying, a sneeze is positive feedback, a baby, get the baby out, positive feedback with uterine contractions, other things that people could think of that were, and then there's a break, because after the explosion, there's a break. So the woman's contractions stop.
Right.
You don't keep sneezing as you keep sneezing, you stop sneezing.
Right.
So here is just consider how PTH regulates ionized calcium with what we know now. So we always knew that there was an error sensor between where the calcium level was versus where we want it to be, which is, the ionized calcium 1.12 to 1.32 millimolar. And whatever there was a difference, we knew the parathyroid would somehow sense it. And then once we knew about the calcium sensing receptor, so for a long time, they thought it was parathyroid hormone secretion. And it is parathyroid hormone, but that's not the controller.
Right.
That's the controlled process.
Yeah.
The controller, just like when we talked about pressure-natriuresis or pressure-capniuresis, it was the
brain.
The CO2
receptors.
It was the ventilation that changed the CO2 levels, but it was the brain that was the controller. And here the controller is the calcium sensing receptor. So here is the negative feedback system. And the important thing is the parathyroid has two things. It's the place where parathormone gets secreted, but it's under the control of the calcium sensing receptor. So when the calcium sensing receptor is unbound, parathyroid hormone increases.
Right.
And then when the calcium's high enough that it's binding the calcium
it shuts off
it off.
secretion.
So that's right. Isn't that a beautiful negative feedback?
Right.
So what you see coming here's the negative feedback. Decrease in calcium, decreased binding, that increases parathormone. And then the PTH does its thing on bone, kidney, and gut. And then the increase in calcium negatively feed back. And the prototypical disease is primary hyperparathyroidism, where the negative feedback gets altered in a way that the normal level of plasma calcium is not enough to turn off PTH. For some reason, there's been a shift.
Right.
And that you're still in steady state, but it's a new steady state at a higher level of plasma calcium. And, that's primary hyperparathyroidism. That's the disease. And hypercalcemia is
Albright.
Albright, yeah. Fuller. So parathyroid hormone is secreted by the parathyroid in response to this. It binds the calcium receptor, which decreases PTH. That's the negative feedback. And the PTH has all these effects. So bone, osteoclasts get stimulated to take calcium out of bone. The kidney gets stimulated to stimulate the 1-alpha hydroxylase, the opposite of what FGF23 does, and that increase vitamin D3, which increases calcium and phosphate from the gut. And then in the kidney, it inhibits the transporter, so it's phosphaturic. And then we now know about calcium channels like TRPV5 along the nephron that are associated with the vitamin D receptor, calcium is reabsorbed. So PTH secretion is inhibited by hypercalcemia, obviously.
Right.
FGF23 feeds back on PTH. So FGF23 PTH levels are rising. FGF23 levels are rising to try to make PTH levels go down.
Right.
Okay, and they're fighting with each other. And then, of course, that was, this is the calcium sensing receptor allowed us to get oral and IV calcium mimetic therapy to try to fool the parathyroid into thinking, okay,
here's all this calcium shut off finally.
Exactly,
right.
exactly. So that's why it's called the calcium mimetic.
Right.
It makes the calcium receptor think calcium is bound, where it's not calcium. So here is, a very important figure from a paper in 2000. I think this is the same figure as reproduced and up to date. And what it shows here the first thing to show is look at these green stars. What you see here is the normal serum calcium versus parathyroid. And you see clearly this curve tells you negative feedback.
Right.
This thing's going up, and this thing going up makes this thing go down.
Right.
That is the definition of negative feedback, which is how you got this negative derivative.
Right.
And what you also see is that we all live in the middle of this operating range, so that the slight changes, this is the gain of the system.
Right.
The gain. Slight changes in the thing being controlled lead to big changes
in the hormone.
Right. So this is where we all are on this curve, and we spend most of our time here, so that our ionized calcium spends most of its time in the normal range. Now, if you don't have PTH because you have primary hypoparathyroidism, then you're hypocalcemic because you don't have PTH. That's pretty easy to understand. If, on the other hand, you're overproducing PTH, and all these blue dots, blue squares, are people that are making too much PTH, and they're hypercalcemic and making too much PTH. And then here's people making PTH from PTHRP or the malignancy of the malignant hypercalcemia, but they're all hypercalcemic from their malignancy. And again, when I trained, we were told, the most common cause of inpatient hypercalcemia is cancer. The most common cause of outpatient hypercalcemia is hyperparathyroidism. So we always said, whatever you do, if you're hypercalcemic, don't get admitted.
Yeah, right. It's funny how that slide lends itself to AI because the data points are so splayed out in zones that you give it some testing data and a computer will never miss the diagnosis.
You think these are splayed out. But anyway, here's where we all want to live. And this becomes clinically relevant for other reasons as well. So note the negative feedback. But the other reason it becomes, and this is sometimes shows up on boards, lithium has several effects on endocrine organs. It causes hypothyroidism, but also lithium can cause hyperthyroidism because lithium. So here's the two sigmoids. You see they're exactly superimposable.
Yeah.
But what's changed is now to
The
shut
set
up
point.
parathyroid. The curve is shifted to the right. So what now? So make a hypothesis, Craig. what could lithium be doing to make the curve shift?
It's affecting the calcium sensing receptor set point.
In what way?
It's making it less, your calcium has gone up, so it's making it less sensitive to the calcium.
Yeah, so let's just say lithium, I'm making it up because I'm not sure. Let's just say lithium interferes with calcium binding to the calcium sensing receptor.
Right.
That's going to have the opposite effect of a calcium mimetic. It's going to say
it's going to raise your PTH.
It's going to raise your PTH because it's preventing calcium is there and high,
right?
But the calcium sensing receptor doesn't see it. And lithium is a cation.
And lithium gets into the cells so well, maybe it's dysregulating something in the cascade after the sensing receptor goes off. That's in line to parathyroid secretion.
Right. But this is a well-known effect of lithium.
Right. That's interesting.
And whenever I see patients who are on lithium, I keep a close eye on their PTH and their calcium.
But you
level.
don't lose you don't lose the regulatory process, because the sigmoid hasn't changed.
No, so what you've done, the slope is the same.
Right.
Kind of reminds us of the pressure-natriuresis. The slope is the same, but there's been a shift. So in pressure-natriuresis, if something increases afferent arteriolar resistance, we get a shift to the right, but the slope doesn't change.
Right.
So here, the same thing. The shift to the right, what's analogous to the increase in efferent arteriolar resistance, is now essentially calcium resistance to the calcium sensing receptor has been fooled. And so this is the same thing as hypertension. It's hypercalcemia, hyperparathyroidism, but it's, again, your observation that the curve looks the same,
right,
shifted, means that it's not changing something else, like like a diuretic changes the slope,
right,
or change in sodium transport changes the slope of pressure-natriuresis. It's just interfering and causing a higher resistance, and that's literally what this is.
Right.
It's sort of a calcium resistance. In the system.
Right.
It's like hey man, this calcium should turn me off.
Right.
But it doesn't, because if you develop some calcium resistance. And I don't know if I'd love to ask Fuller Albright. I wish he'd call in. And
funny.
I wish he would call in.
Hey, Alan, we got a call.
Oh, who's it?
It's Fuller Albright.
What do you want to know?
He wants to know why lithium shifts this curve and what's happening to the calcium regulation.
Well, first of all, to Fuller Albright, I want to say several things. First of all, you're my endocrinology hero.
That's awesome.
Number two,
he says he also wants you to know he discovered RTAs.
Oh. Well,
did you know that?
I think that, yeah, I think I knew, but he's usually too modest to say it.
He wanted to mention it specifically to you. He loved your talk on RTAs, so he just wanted you to know he had something to do with that.
Nice. And some of those are partial. So even though his name is Fuller, some of them are partial. But the other thing that apparently he gets credit, quote, for confusing people, is when he did his hyperparathyroidism work, he also did hypoparathyroidism, and then he described pseudo-hypoparathyroidism, and then he described pseudo-hypoparathyroidism.
What is pseudo-hypoparathyroidism? I've never actually heard of pseudo-hypoparathyroidism.
Okay.
I'm sure I came across it in a book if it's there, because I read them all.
Well, it's double negative. So,
right.
So let's just go from the short words to the long words.
Okay.
So if you've got hypoparathyroidism,
yes,
you're hypocalcemic because you're
not producing enough parathyroid.
Right. So that's easy. Primary hypoparathyroidism. Now, let's say that your parathyroid gland is producing PTH, but the target organs are resistant to it. Okay.
Pseudo-hypoparathyroid.
That would be pseudo. It looks like your parathyroid level is low, but when you measure it, it's high.
Right.
That's usual pseudo.
Okay.
Like Little syndrome is pseudo hyperaldo.
Right.
But because when you measure it, it looks like aldo's high, but when you measure it, it's not. It's completely suppressed. So pseudo-hypoparathyroidism is, it looks like you're not making PTH, but when you measure it, it's high, but the organs are
But
resistant.
Phenotypically, you look hypothyroid.
You look hypoparathyroid because the organs are ignoring it.
Okay.
Now, pseudo is, since pseudo is, it looks like your PTH is high, but it isn't. Since pseudo means it looks like your PTH is low, but it isn't.
Right.
Pseudo is your PTH is low. And
it looks like it isn't.
But the reason it's pseudo is because the phenotype that tips off the diagnosis is a phenotypic change in bone. It's a genetic problem.
Okay.
And the genetic problem has its effect on bone. And so they have the bone phenotype of somebody that looks like they have pseudo hypopara.
Okay.
Okay?
Yes.
But they don't
have hypopara.
They don't have
they have a different reason.
They don't have pseudo hypopara that leads to the bone disease. They have pseudo because the bone disease came first.
Okay.
So it depends what comes first.
Oh, I see.
So the genetic defect causes a bone problem primarily.
What's the PTH level in the pseudo?
Well, since hypo PTH would be low and pseudo
would be normal.
Would be high.
Pseudo
is low again.
Okay. All right.
But it's because there's a primary change in bone.
Got you. Okay.
And I think so he's hated for that, because how many pseudos can you put on there? But I think that when you do have more than one pseudo, it tells you that the defect is somewhere outside
distal.
The axis you're looking at. So it's the reason it's pseudo. Let me tell you.
Yeah, that's good. You're 2 steps away.
Yeah,
in pseudo.
Let's say you got a problem with bone.
Okay.
And you wonder whether it's got.
You're holding the cup up.
Yeah.
Hold it so they can see it.
There you go. Let's say you got pseudo. Let's say you got a problem because somebody says, well, you don't have enough coffee.
Okay.
Hypocaffeinemia. Well, if it's got nothing to do with coffee, you can explain a lot of things. That's not only is that's pseudo. Like, I've got a piece of sleep in my eye, and sleep has something to do with coffee. So maybe I have pseudo coffee, but no, it's got nothing to do with it.
Right.
So it's totally pseudo.
Right.
As many pseudos as you want, because it tells you that they're disconnected.
Yeah. Okay.
And so the thing that disconnects all the other PTHs, hypopara, pseudo-hypopara, pseudo is disconnected because it's bone first.
Right. Okay.
Whereas with the other ones, it's bone second.
Okay.
So it's primary versus secondary. Could have called it secondary pseudo. It doesn't matter. Right. But anyway, thank you for your call.
Fuller. That was Fuller.
Thank you for your service.
Yes.
Thank you for discovering stuff in 1938 that was so good, it didn't change for 50 years.
Right, exactly.
You're so
Cushing's
good.
too.
You're so good.
But we think, amazing.
And I don't know how much lithium has been used for the treatment of bipolar disease, but not going back to Fuller's day. Lithium, I think, came around in the 50s. And even though Fuller lived during the lithium, I don't know how many cases of lithium hyperpara were reported about. Guarantee you, if Fuller was alive, he noted it. He got his journal at home, and if he didn't write the journal, he read it.
Right.
So he was awesome. So again, we've known this for a long time. Okay. So one other player I want to introduce now is Klotho. And, the reason I'm introducing it is because we've already looked at this, phosphate being late, PTH and FGF23 being high early on. But one thing that seems to be the earliest, vitamin D seems to go down. But even before that, let's see this thing called Klotho, and we'll get back to that.
Yeah.
That seems to go down real fast.
Yeah.
Okay, or very early. So it seems to be an early and sensitive marker of CKD, and I think this is going to be an important point. So here's all of our curves, and you see now the FGF and the PTH going up along with the phosphate. Vitamin D goes down for all the reasons, and vitamin D going down again. Two reasons. One is you're losing kidney mass.
Right.
And two, FGF23 is inhibiting it.
Right.
And then you see this black line, which is disconnected from all the others, which is Klotho.
Just declining Klotho.
And then here's something I think that comes right out of Miles Wolf's work.
Yep.
You said you talked to Miles.
I did.
Yeah.
And
is he calling in today?
Oh yeah, he might. Hey, it's funny you should ask. He was just calling in.
His ears must have been ringing.
He wanted to say thank you for showing a couple of his slides, and we appreciate all the work he's done.
So what is this slide?
Yeah. So that slide, I love this slide because this slide.
You showed this at your talks.
I've showed this at my talks, and it shows the different stages. It just basically shows FGF23 levels in different diseases. So, it's got hypophosphatemic rickets there. It's got normal, the healthy person in the beginning. You can see the first one.
So the blue means that
which
the
about
kidney's
50.
Okay.
Yeah, blue is normal.
Is this pseudo CKD?
Yes, that's pseudo CKD. Is that hypophosphatemic?
Yeah, this
rickets?
is yeah.
But
if you're focused on the kidney, you call it pseudo CKD.
Yes, that's pseudo CKD. Yes, okay, good point.
You see what I'm trying? This is what I'm trying to say.
Yes, it's perfect.
If you're looking at your favorite thing and everything's referenced to that,
right?
Any rise in FGF23 is pseudo CKD.
That's right. It
looks like CKD,
but it's not.
But it's not.
Right. It starts here.
Exactly.
Oh, that's good.
Yeah,
good.
Yeah. So
I think this is important because FGF23 levels here normally would be like in the 50 range. In CKD, which is our population, the orange bars there, you can see as the stages go up, the FGF23 levels go up. And you got to notice the y-axes here because there are these breaks there.
Right.
And the levels that you get in advancing kidney disease are astronomical. And then as you get transplanted, the other important thing you can see early in the transplant, a few months later, you see the FGF23 drop. And then 1 year later, you see them really drop even to below a little bit normal levels.
Right. So what would be kind of nice to have on this slide is because there's a such thing as called post-transplant hypercalcemia or post-transplant
hyperparathyroid, tertiary.
Yeah. Well, yeah. So the question is, if somebody's end-stage kidney disease has gone on long enough that they've got some tertiary, which is the parts of the islands of parathyroid tissue that are functioning but not listening. And that can take people with post-transplant hyperpara can have bone pain, shoulder pain. It could last for a year. So do you happen to know, the FGF levels are still up early after the transplant, but they fall at a year back to normal.
And the PTH levels stay high much longer after that, and that doesn't really go away.
Right. So let's try to think for just a second, just improvising, why that could be. So since PTH and FGF23 have similar actions on the kidney for phosphaturia, but opposite actions on the vitamin D enzyme,
right.
1-alpha hydroxylase. If FGF23 has gone down faster than PTH, then FGF23...
Then PTH is going to win in terms of its vitamin D effects.
Right. And so that's it, because the FGF23 level comes down faster, so the inhibition on the 1-alpha is relieved.
Yes.
And PTH is not coming down as fast because
your vitamin D.
Because the bone is what's producing FGF23 and those osteocytes stop.
Right.
They're getting the message. But the autonomous functioning parathyroid tissue
is not.
Listening. And then all of a sudden, vitamin D.
When the brakes come off vitamin D from FGF23, then all of a sudden your vitamin D levels go up and your calcium's going to go up.
Right.
Right.
So
that's interesting. I didn't think of that.
Some of those patients, right. So we're just improvising on it. So, that's what's nice about it. But that's why some of those folks.
But there's a dynamic interplay between these things.
Have you seen some of those post-transplant hyperpara people be treated with cinacalcet?
Yes.
I haven't treated anybody for it, but I've seen it.
Yeah.
You got to be careful.
Yeah.
Giving cinacalcate to dialysis patients, cinacalcet, obviously the big side effect is the worry about hypocalcemia.
Right.
You're shutting off PTH.
Right.
In end-stage renal patients, kidney patients, the PTH level is so high, it's unlikely that you're going to be able to shut it off. But when you give it to people with good kidney, you can still get away with it in post-transplant because the PTH levels stay high. But you're giving it to regular folks. Like when you give it for primary hypo,
they could get severe hypocalcemia.
So people that have kidneys, unless you have primary hyperpara, and you have good kidney, and
you excrete the calcium,
and you're not gonna get surgery with the parathyroid. But just like hungry bone,
right?
When someone's parathyroids come out, and all of a sudden the bone takes back all that stuff.
Oh yeah.
You get
they remineralize.
And the serum calcium can go dangerously low, and they get
right.
tetany.
Yeah. The one other important point on that slide is the second one, which is the primary
bone disease,
hypophosphatemic rickets, right? And so those people create this, have a very high FGF23 level and a very low phosphorus. So I think, there's different phenotypes on this slide. There's people who are having the progressive kidney disease and a rising phosphorus, which is probably driving their FGF23. And then you got this other group where that FGF23 is primary, and that's the defect, and that they're just producing excess. So it's kind of like primary hyper FGF23 and secondary FGF23.
Right. This is primary. Right. We can call this not only can we wrongly call it pseudo CKD.
Yeah, pseudo CKD.
We can call it primary FGF23emia.
Right.
Because the problem's in bone. Right. Bone is the endocrine organ that makes the FGF23.
Right.
And so, you're exactly right. And that's why it's important that it was blue colored.
Right.
Because to show that, first of all, kidney was fine.
And I think there's problem is in some cleavage of deactivating the FGF23. So these people have this super high functioning, unable to be shut off FGF23.
Right.
It's not even that they're producing so much. They can't disable it.
Right.
They can't cleave it.
Right. Okay. So here's Miles.
Yeah.
I don't know if he's still on the phone, but if he's still watching.
Yeah.
I
love this slide.
I heard we're up to 2 viewers.
I think we might be up to 2 viewers, but we talked about relatives. I have a few relatives that watch. So
right, but I told you that
2 count for 1.
2 relatives is only 1 viewer.
That's true.
Because you never know, one of them may be forcing the other one. Like if it's your mom and dad, maybe one of them is forcing the other one to watch.
We're going to celebrate when we hit 10 or 15 views on one of these.
But we have to. Again, I don't think we should count relative couples because we don't know who's being held hostage.
That's true.
To watch this stuff.
That's true.
So here's Miles in a Nature Review Nephrology review from 2014.
Yeah.
This is one of your favorite slides.
Yeah,
What do you show this slide for?
Well, I show this slide. I show this mostly because it shows the many different places where we can treat people for this and where we can intervene. And that there's the public policy segment of this, there's the clinical applications, and then there's sort of the basic science part of it. And, you know, I think if you look at this, it starts off with the public policy stuff. Look, you tell someone to eat a low phosphorus diet, it's impossible to do because no foods are labeled with how much phosphorus is in there. I don't know what the regulation is as far as how much they can put into some foods. Like, is there some limit? Are they allowed to put anything they want? It's such a good preservative. You know, are there laws about how much they can use in something? No,
I don't think there are. I think, first of all, even if you look at the dietary recommendations, the national guidelines, it's hard for them to know exactly how much phosphate intake to recommend because the phosphate intake of the ingredients does not translate necessarily to the phosphate absorption. We're going to see that.
Right.
So phosphate's not just, phosphate on the outside world doesn't translate to predictable, the same amount of phosphate in the outside world. You have 2 cans of something, have the same phosphate.
Right.
You know, and then the person eats the 2 cans, one can and the other can. There's no way to know, predict which one. They're certainly probably not going to be equal.
Right.
Because there's other stuff in there. But yeah, so the first thing is, the factory, the food industry has to do something.
Right.
And then, shoppers have to have other choices. You say they can't avoid it.
Right.
Here in Vermont, we love Ben & Jerry's ice cream, but, everything, the reason it's so hard for dialysis patients to limit their phosphate is because everything that tastes good
is got a ton of phosphorus.
Yeah, but you want a pizza.
Right.
I mean, I probably don't eat a very low phosphate diet if I eat any Ben & Jerry's.
Right.
If you have the typical night out on Church Street where you have a pizza and Ben & Jerry's,
you're done.
They have to go together.
Right.
And you can't put the Ben & Jerry's on the pizza. So you have to have them separately.
That's true.
And I just chomping a couple Tums in between on the walk down Church Street. But yeah, it's unavoidably in the diet. And then once in the diet, it's in our bodies. And once in our bodies, it can affect everything from the bone to the blood vessels.
And then this is from a treatment standpoint, all the different things. You can lower additives. You can change how people shop. You can change a person's diet. You can try to reduce their phosphorus absorption from the gut, with binders.
Yeah.
Then you can have impact on the bone, maybe by inhibiting FGF23, or you can affect the FGF23 receptor, to kind of impact how your phosphaturia, what your mechanism of phosexcretion is.
Right, because phosphate may make FGF23 go up to try to be phosphaturic. But there's also, I think there's some at least experimental substances that interfere with FGF23 metabolism or block it. So anyway, yeah, this was a great slide from Miles. Thanks again, Miles. And we got one list.
The crowd, they heard Miles. They were so excited.
But it looks like, but I'm just looking at our viewers and Miles dropped off.
Yeah, he just left.
He left. He said, that's it. So then, this brings up what you said, where do you start? Who's the boss of this? And you just, you found out that phosphate was a good place to start. Fred Coe told me phosphate was a good place. Let's talk about phosphate. Yeah. So it's absorbed by the gut, which is promoted by the activated vitamin D3 stored in bone, and that's regulated by the FGF23 PTH. And then reabsorbed or not, depends on the levels of FGF23 and PTH, going on in the kidney. Now in CKD, we often see, as we've mentioned 1,000 times now, hyperphosphatemia with secondary hyperparathyroidism leading to bone disease. And again, this is the thing with the decreased survival and accelerated aging. So we have spent a lot of time clinically controlling hyperphosphatemia. I mean, this has been the thing we've spent most of the time doing. Oral phosphate binders to prevent phosphate from being absorbed if you have to eat it, and you have to take your phosphate binder with your food, otherwise it won't get bound. I've seen people who don't time it right, so they'll take a calcium-containing substance and they'll get hypercalcemia because the calcium gets absorbed, because it's not getting complex with the phosphate. And then there's the Rocaltrol, the calcitriol, and then our calcium mimetics. Now, the emerging treatments, I've been excited for years about tenapanor. Tenapanor is a different kind of way. It's a small pill.
I haven't heard of tenapanor.
Yeah, it's a small pill, and I think it's been around since 2015 or so. I have not seen that it's been FDA approved, but there's been some studies in journals, including, I think, in the New England Journal, showing it's a small pill that has a novel way of decreasing phosphate absorption.
So like nicotinamide, like that kind of effect?
Well,
like
it affects the transporters.
Okay.
So it's
in the gut.
In the gut. So it's a transport effect. And so that's why the pill doesn't have to be big. It doesn't have to have this mass to have binding sites. Okay.
Right.
It's affecting transport, which makes much more sense to me and to you. And then, the question about, and we'll get to the Klotho, we can replace that. But I think we're getting the idea that the phosphate is a late sign, a bad sign, but but a smaller and smaller tail wagging the dog.
Yeah, I kind of feel like, I mean, phosphorus to me is like glucose and diabetes.
Right.
I feel like the phosphorus wants to go up early on, and all these other players are able to keep phosphorus in check so that even as you're losing nephrons, your single nephron excretion of phosphorus goes up to the point that you can maintain the stable serum phosphorus level.
Well, take diabetes again. Let's say that instead of giving, and the defect in diabetes, of course, the main defect is either a lack of insulin or the lack of the effect of insulin.
Right.
Let's say, though, that we treated diabetes by glucose clamping people. So we put them on a glucose clamp. So the glucose couldn't change.
Okay.
But we did it without insulin. So we found another way, another non-insulin way of clamping glucose. Which of the ravages of diabetes would be treated by making sure the glucose didn't go up? I mean, would diabetic nephropathy not happen? Something tells me it still would.
Right.
Because insulin, like so many major
growth factors,
has so many different receptors and so many different functions that the insulin defect is. So it's diabetes treatment is more than clamping glucose. Really, you got to have insulin back. You got to have beta cells.
And I feel like this is the same way. This is much more than just clamping phosphorus at a normal level.
Exactly.
But my point is that phosphorus is the problem that's being handled here.
Yes.
As you're losing Klotho, you can't get rid of phosphorus.
Right. So
it wants to go up, but then FGF23 goes up.
But it would be, the question is, it would be kind of silly to treat diabetes with just glucose clamp and no insulin.
Right.
Is it equally silly to try to treat the problem we're talking about with just phosphate clamp, irrespective of the other things that are happening? Right. And I have a feeling that it wouldn't help that much. So again, the long sought after phosphatonin, is there a phosphate receptor, phosphate sensor? And, this is a paper from 2018 or 19, 2019 in Nature Communications that basically there's the title. What's the title say?
Yeah, phosphate acts directly on the calcium sensing receptor to stimulate PTH secretion.
So, in addition to the parathyroid having calcium sensing receptors, and the calcium sensing receptor being all places that we've talked about it being, and the calcium sensing receptor possibly being affected by lithium, because it is, it's promiscuous. I mean, in the lab, it's affected by aluminum.
Mm-hmm.
I mean, back in the days of the aluminum would have been affecting calcium sensing receptor. And so if there's calcium sensing receptors in the brain, maybe that was part of I think it was more of a buildup of aluminum. But this title is making the argument by using the word directly.
Mm-hmm.
I mean, it says direct and receptor.
Right.
That's not like, that's short. Okay.
Yeah.
And so here's the question. So what's going on in this paper? So in this paper, which I think is kind of interesting, very interesting actually. So here's PTH secretion versus time.
Okay.
So what they do here is you first see that at
a calcium level.
Yeah, when they lower calcium, PTH goes up, just like you'd want it to be.
Right.
Okay. So they say, okay, it works. Our assay works. The question is, what happens when they just change phosphate? So here they lower phosphate.
So they keep calcium at 1.2, which is where it is in the beginning.
Yeah.
Okay.
And then they lower phosphate, and you see this.
Yeah. Then they stepwise change the phosphorus levels.
So as you see, as the calcium is clamped, quote, the phosphate level goes up, and the PTH curve doesn't stay flat.
No, it goes up.
It goes up. And the question is this going up is this
going up because of the change in phosphorus or because there's some time effect?
Right.
But as soon as they switch back to a low phosphorus, it drops.
Right. So the question is clear that there's a correlation between what they're doing to phosphorus and PTH secretion.
Yeah.
But is that being mediated by the calcium sensing receptor?
Okay.
So here the data show, again, you see the same kind of steps going on. And in the presence of constant calcium, so again, calcium is being clamped.
Clamped at 1, 2.
And here's PTH, everything normal.
Yeah.
And then step the phosphate up and step it back down. Got a nice little dose response.
I mean, that's amazing.
Okay, so fine.
Okay, so phosphorus regulates PTH.
Well, it does, and the question is it through the calcium sensing receptor?
Right. But yes, okay.
Okay, and these are human parathyroid cells. So what they showed in this paper is when they knocked out when they had knockout animals knocked out for the calcium sensing receptor, phosphate lost its effect. So as if it was being mediated. So here's what they came away with in the paper. So the calcium sensing receptor is active when it's closed.
Right.
Okay. So that when there's calcium around, and the calcium is adequate, this thing, the parathyroid hormone is decreased, but because the calcium receptor goes into this state. In CKD, things are kind of not good. You can sometimes get hypocalcemic because of the change that we talked about, and the phosphate levels go up. And it changes the conformation of the calcium sensing receptor, and PTH goes up because it's open and active.
Right, because your calcium's low.
Yeah. So they're saying that the different experiments they did on human tissue and on regular mice and knockout mice, that they were saying that the phosphate influence on PTH was mediated by the calcium sensing receptor. So this is really a provocative paper. Now, one thing I'm worried about is open means that this, when things are open access, what that means nowadays.
Not peer reviewed?
It's not that it's not peer reviewed. It's that your chances of getting accepted depend a little less on the science and a little more on your pocketbook. So
right, so you can pay to get it through.
Open, there's a big difference between open and free. In fact, they're opposite. So I've written papers lately where I sent them to a journal, and a lot of journals are doing this now. I sent this to a journal for review.
Okay.
The paper gets rejected. And in the rejection, right after you get the rejection email, you get another email from the same journal that says, well, do you want us to transfer this to our open access journal? Same journal has an open access journal.
Okay.
Okay. Now the page charges, if it would have been accepted by the journal, they're reasonably low. It goes out for review. Doesn't cost that much. The thing you have to say okay to before they'll transfer it over to their other journal is, by the way, if the other journal accepts it, here's how many thousands of dollars we now want to publish it.
Right.
So you start to say, well, wait a second. You've just rejected my paper, but now you're saying I could get accepted. Same paper.
Yeah.
And if I pay more money, it gets accepted. That to me kind of looks like somebody gets into college because somebody bought a building.
Right. Yes. No, I hear you.
Right. It doesn't change their grade point average.
Yeah.
So the fact that I think to me, I take with a bag of saline.
Right. Okay.
I mean, I'd like to think science is science.
Right.
And nature is nature.
Right.
And I think open access at Nature Communications is probably more reliable than something else. But when you see this right up top,
can it be? But
open. I thought open was about the receptor.
Can it be rejected? Can it be? But it couldn't be rejected. So they had to semi approve of the science of what they saw.
No, they don't say that.
They don't.
They just say.
So essentially, it's not peer reviewed.
They just say, we got. It's like going to a play.
Okay.
You show up to the Majestic Theater to watch Phantom.
Right.
And you say, I would like an orchestra seat. Oh, the orchestra's sold out. We can sell you a mezzanine ticket.
Okay.
Okay. The difference here is that the mezzanine ticket is usually less than the orchestra. But here is if the theater says, okay, we can't get you on the floor. The orchestra's sold out. We'll give you a mezzanine seat. but it's going to be 10 times expensive.
Right.
And you go, oh, wait a second, same play, worse seat, same play.
It's the scalpers.
I don't know. And then who knows what the balcony is going for.
So this basically is before the peer review process, though, because
well, no, what they say is, if you give us permission to, we're going to make it easy. We're going to take the paper you already submitted, but you haven't done anything else. We're going to transfer it to our other journal.
Okay.
Okay. And we're willing to do that. But we want, two things. If they accept it, it's accepted. And this is the fee.
Okay.
Okay.
Got it.
So that's what they say. And so you basically have to make a decision that you didn't make the first time.
Right.
I submitted it the first time without worrying about, are you sure you want to submit this because it's going to cost us much money? Now they're saying, are you sure you want to submit this? We've got it, make it easy for you.
Right.
But it comes with this fee if it's accepted. So if this paper is accepted, you're paying this fee.
Right.
And then you have to check your wallet. You don't check the science.
But this looks pretty good.
It does look pretty good.
Pretty clean.
I'm only saying I would be a little bit more comfortable.
Right.
If I knew these authors had to pay some extra money. There was just a thing on Twitter last week. I don't think I'm talking out of school when I say that somebody showed a picture from Nature, of an article in Nature that says, we got to do something to make sure that everybody's got equal access to science.
Right.
And meanwhile, they show the paywall to read the thing in Nature. So on equal access, they're writing an article about equal access, but it seems a contradiction that you have to pay for the article. And then somebody writes, I think somebody did a comedy video on what it costs to get a paper published in Nature, the open access Nature.
Mm-hmm.
It's more than $11,000.
Unbelievable.
Okay.
Yeah.
So it means that all of a sudden what you're going to get, even if the science is as good, if two groups do the same science, and one group doesn't have $11,000.
Right.
So what's getting published is the people that
can pay.
That can pay.
Right.
And that
which is the world we live in.
Which is the world we live in, but
what money
is
can't buy.
But you don't, something gets lost.
Absolutely.
So anyway, I think I wanted to review this because I think this is very excellent.
I love it, but going back just for 1 second, even to the title, that phosphorus stimulates PTH secretion. If we apply that then to our CKD patients, how do you put that together? What would that mean in terms of the regulation? Okay, so you get someone who's developing progressive CKD.
Yeah.
Their phosphorus level wants to go up. That would then itself be a trigger directly for PTH to be secreted and part of the...
No, this paper isn't saying that secondary hyperparathyroidism is going to get better. What it's saying is you've been looking for the phosphate sensing receptor.
Yeah, and we found it. Yeah.
That's all it's saying. It's saying we found it and it does what we always knew it did.
Right.
And knockouts, it doesn't do it in the knockouts.
And does it do it? Do they say where they think it does it? Like, does it do it in the same pore where calcium binds? Is there an anion section to this?
Yeah,
they're different, calcium and phosphorus.
Well, no, but they're showing, according to their diagram, they're showing the same.
They're plopping it in the middle.
Yeah, they're showing. Yeah, they're plopping it in the middle. So this is what they're saying. Okay, and so
because so many times these channels and receptors are charged and they're related, and to think that something that's
I can believe it wouldn't, if somebody told me, hey, turns out that if I talk to God and God says, hey, I want to tell you something, there's a phosphate sensor. Yeah. And so it's
Alan, it's God.
It's God. So God says, Alan, I'll answer the most burning question you have.
All right.
Do you want to know about life? Do you want to know about how I created everything? You want to know about any of that story?
And Alan's like, no.
Here's what I want to know.
All right, let's have it.
Here's what I want to know. What's the phosphate sensor?
Right.
And God says, ask Miles. So anyway, that's give we have to see more data.
Right.
Again, nothing is. We've all seen great, exciting papers that nobody could replicate.
Right.
Exactly. So I think it's important. This is we present it as something that's out there.
Right. As a possibility of what's sensing phosphorus.
Nature Communications, even open access, is not That's not
right. Not the end all.
No, that's not. But it's also not. It's not chopped liver.
Yeah. This, I think, is an important slide because
Okay,
this slide is from my case for this slide, and why I sent it to you was because this is one of my points about the effects of phosphorus even in the normal range. And these guys looked at, it was like 4,000 patients. I think the number's on there, 4,100. Yeah. And this was in Circulation 2005. And they just grouped people with by phosphorus levels and then tracked them and monitored them. And I think it was over 3 to 5 years. It was something along those lines. And when they looked at all-cause death, they looked at non-fatal MI and fatal MI, and new CHF, these correlated with buckets of phosphorus. So that a lower phosphorus, 2.5, less than 2.5, 2.5 to 3.4, and then the 3.5 to 3.9, and over 4 was the highest risk. These people were like, I can't see what the risk is, but the odds ratio, the hazard ratio was much higher, like 1.3 in the over 4 group. And then our CKD guidelines say, oh, well, if you have stage 3 or 4 CKD, keep the phosphorus below 4.5. Like, that's the highest risk group. And people come in and say, oh, my phosphorus is normal, it's 4. And I laugh because I really feel phosphorus should be on the cardiac panel. It's not. People come in with an MI and they get their labs done and you don't know what their phosphorus is. They come in, the creatinine's 1.5, and it could very well be, they're in this higher risk group, and those are people I would talk to about diet and other things. But I think this just shows us, look, we accept a phosphorus of 5.5 in our dialysis patients.
Well, maybe don't forget, this is, again, I want to say the tail of the dog again, but it's kind of like that because these folks, as you lose kidney function, you go into positive phosphate balance, and the skeleton may be where all this stuff is. When you measure the serum phosphate, so somebody says my phosphate is normal, in the blood it's normal, but we haven't measured your skeletal phosphate. What about the burden of skeletal phosphate? Those people are almost invariably in positive phosphate balance. And so when you look at the survival data, to the extent that the survival data correlates with phosphate, is it the phosphate is it the phosphate you can measure?
Right.
Or is it the phosphate that's sitting there ossifying the blood vessels and stuck in bone?
And maybe those other processes aren't, it's hard to know, but it seems like, because if you change people's diet, their phosphate levels do change consistently. Like in a steady state, they reach some new little steady state of a higher phosphorus. So it's not like they're phosphorus clamped. We're not phosphorus clamped. If we change our intake or if we change our output, our serum phosphorus changes. And although we're in a positive balance and there may be some negative effect impacting like calcification of other tissues, like soft tissues, then non-bone calcification, that could be, that's what's going on. But it's hard to know. But in my mind, number one, I see serum phosphorus on blood work as an important lab that should be done routinely, probably in most people with even normal renal function. I just think it's an important lab to know what's going on because it reflects diet.
Right.
And it impacts cardiovascular risk.
Well, I think a lot of these things, the basic metabolic profile makes a person think, anybody who goes to the lab knows that there's a basic metabolic profile and a comprehensive metabolic profile.
Right.
The basic one is probably the one with the stuff that is important and relatively cheap and easy to measure.
Right. Okay.
And it is harder to measure a phosphate than it is to measure a sodium concentration.
That's interesting.
And so what we would say is basic to the metabolic profile of a person like us saying we want to assess what we want to assess. Basic means here's what's cheap.
Right.
Here's what's important and cheap. The monovalents are easier to measure.
But the other reason I think this slide is important is just to put into perspective these levels.
Right.
And that even in the normal range, there may be some change in cardiovascular risk, even in people who seem to be in the normal range, but they're in the upper normal range.
Right. Well,
I'm not saying it's the phosphorus that's toxic or causing this, but it may be reflecting something else. Like maybe the people over 4 are reflecting a slightly lower Klotho or a slightly higher FGF23.
Well, you remind me of the story of the farmer and the horse.
Let's hear it.
So the farmer has this great horse. He loves his horse. The horse does everything for the farmer. And one day, to the farmer's horror, he finds out that the oats barrel that the horse is eating out of has been contaminated with sawdust. And he looks at it, turns out to 25% sawdust. But the horse is doing great. Horse doing great. So the farmer then thinks to himself, the horse does well. I'm saving money on oats. 50% sawdust, 50% oats. Horse is doing great. Okay? Everything's fine. Serum levels of phosphate are normal. Okay?
Sawdust levels.
75% sawdust.
Oh.
Horse still doing fine. Pulling the plow, doing the thing. The farmer, of course, goes to the nth degree and says, 100% sawdust. The horse drops dead, and the farmer says, what happened?
Right.
So, again, the, quote, phosphate level looked normal.
Right.
All the way up from stage 1 sawdust to
Right.
stage 2 sawdust to stage 3 sawdust, and then stage 4 sawdust killed the horse.
Gone.
And again, we have to keep those stories in mind. Okay, sorry, those were numbers you wanted.
Yeah, I think that was just a key to see what our goal is, and is that really normal. The other thing I'll say is like a lot of times in and it's funny, phosphorus, we don't really have good evidence for any of the phosphorus levels that we're treating people to.
Well,
so
I think we're going to show that.
And then lastly is that the we're told to hold binders. Like some of our protocols say, if there's an optimal phosphorus level is 3.5 to 5.5, and if they're below 3.5, hold the binder, which I don't do actually. I hold it below 2.5, right. Just for nutritional issues, because a lot of times in our patients it reflects.
Well, you have to make sure you have to make sure that a low phosphate level. You have to say, okay, is this because I'm treating them well,
right,
or is it because they're not eating?
Exactly.
There are those rare patients who are on nocturnal hemo who could come off phosphate binders,
right? Yeah.
And again, maybe they're coming off because the phosphate
clearance
levels
is so much better.
The clearance is great, but we also have to. The differential always has to be check with them, make sure that they're eating. Eating.
Okay.
So here is exactly your point. That slide introduces the relationship between phosphate levels and survival. And again, here's the things. It's the phosphate level, but it's also their age and their nutritional status and their inflammatory status. So here's a paper that's pretty new from 2021. So it's looking at kind of recent data. And let's look at some of these numbers. So here I think you see the usual Goldilocks curve. If there's an optimal phosphate, and being too low is not good, and being too high is not good. And you just look at let's just look at the red curve, because these are all ages. And clearly what you're seeing is in the fully adjusted model, there's a U-shaped curve. And it is not good
to have a very high phosphorus
level.
High
phosphate in terms of survival.
Right.
But that doesn't mean it's driving it. Again, we talked about in Pressure-Natriuresis, you can plot anything.
Right, exactly.
Okay?
Right.
Plot anything. Here's that data broken out by age. And what you just basically see is it recapitulates. Some people, when this happens to young people,
I think that's really important that it's broken out by age, because we're in different levels of aging, of everything, of cellular growth. We actually don't even start aging until we're after the teenage years. In the beginning, we're growing, and everything is.
When's Paul Rudd going to start aging?
I don't think he's ever going to start aging.
Yeah, I mean, the guy, not only is he not aging. I looked recently at pictures of him when he was, right. I think he's 52. I looked at him a picture when he was like 32. There was a 52, and not only does he not age, he actually got handsomer.
Yeah, he looks great. I mean, gotta love Paul Rudd.
Oh, gotta love Paul Rudd.
Oh, he's amazing.
I think it would be great to get him on the podcast.
We're gonna need to get him on the podcast.
I mean, what I think now, that would be an example. If he watched the podcast, I would say that would be equivalent of 2 viewers.
Yes, that's a 2 view.
Because Paul Rudd is going to live to be 1,000, so he's got to count as 2.
Oh my God!
Can we get Paul Rudd?
I'm gonna work on it.
I mean, come on, people. I mean, he's a very nice guy.
He seems to be.
Yeah. And
so funny.
Yeah, very nice guy, very talented guy. And yet I have heard him say, people say,
what does he say about phosphorus?
Well, he said, what about how you explain, how you don't age? And he goes, because I haven't spent any time trying to understand hyperphosphatemia.
That's it.
With all these errors, because that'll age you real quickly.
Oh my gosh. That just depletes you of Klotho.
I've heard that people have lost their hair about that. I don't know.
Yes.
I don't know if that's true.
I think it is.
But yeah. So get him as a viewer.
Okay, I'm going to work on that.
I mean, that's your job.
I will.
Here's what happens when you add phosphate binders. So here's oral phosphate binders. And the black is people not on phosphate binders, and the red's with phosphate binders. You still get the U-shaped curve, and the question is: so let's just look at the red versus black survival. It ain't that different. I mean, I don't know that I'm looking at these two. I mean, the red is below. That's good, but is that significant? I mean, I'm not sure it is. And when it does become significant, look at the levels of phosphate. The lines are not really diverging until you're above 10. We don't let people get into the double digits. So
who are these are people with
CKD.
Yeah. On dialysis?
And, some they broke them up by age.
Okay.
Then there's not enough dialysis patients, so they broke them up by age. And so this is again the age group again. And so where do who benefits the most from phosphate binders? The old people or the young people, where is it going? But again, the more data you look at, I mean, the U-shaped curve tells you two things. It tells you that there's a Goldilocks phenomenon, but it doesn't tell you what's controlling it.
Because what's funny in that cardiology study, the lowest phosphorus group had the lowest risk, below 2.5 phosphorus.
Well,
it didn't show a J curve.
Well, that's what I'm saying. Science marches on.
Right, exactly.
So, yeah, I mean, all I can tell you is that this is a lot of people, and it's more recent.
Yep.
You were looking in 2005.
That was 2005.
Yeah, and everything, yep. I mean, that was before FGF23. It was before who knows what the practice pattern was.
Yeah.
This is recent data on a lot of people. They had enough people to break out 4 different age groups.
Right.
So, what I take away from this is the Goldilocks, and that binders, for all the trouble they are. I mean, it's like the war. What is it good for? Phosphate binders. What is it good for? So it doesn't make me more excited about giving phosphate binders. Okay, to people. So let's just see maybe not. If we're breaking it down here, it may not be phosphate. Here's one of your favorite slides. Tell us what's going on here.
Well, this is Sharon Moe.
Yeah,
we love 2011, okay. And this was, I think, it was 9 people, and she brought them into a hospital, and she looked at dietary phosphorus and the impact of that on phosphorus levels, on phosphorus balance, and also on FGF23 levels. And she wanted to see, was there a difference in people who received the phosphorus via a vegetarian or an animal-based protein intake phosphorus load versus non-animal based. So she had a vegetarian diet. This was inpatient, and these people acted as their own control. So it was a crossover, 1 week on each diet. And when she did that, so some people did the vegetarian diet, then they crossed over with a 2 to 4 week washout, and then they came back and they ate the same 800 milligrams of phosphorus in an animal protein diet.
800 milligrams in the can.
It was 800 milligrams in the can, and it was either vegetarian or meat-based. So go to the next slide, I think.
Okay, so this is the protocol.
That's the protocol.
Okay.
1 week on each diet. And, what I took away from this was 2 things. One is when you ate it with when you ate the vegetarian diet, your phosphorus was lower and your FGF23 level was lower. So, the same person, if they got 800 milligrams via a can of animal protein, animal based phosphorus, it was higher. And if it came from a vegetarian source, it was lower. And that also lowered their FGF23. And at this time, thinking FGF23 is so bad for vascular calcification and LVH, in my mind, it's one thing that points to why vegetarian or a very low animal protein diet is a healthier diet for your kidneys and your blood vessels.
Well, I think it may be, to me, in addition to these very important things, I think the thing that struck me was 800 milligrams of phosphate went in.
Yeah.
But 800 milligrams of phosphate did not come out. So here on the meat diet, the 24-hour urine phosphorus is this.
Right.
Okay. And what is that?
778.
Nearly 800.
Right.
Okay. So if this is if they 800 milligrams, 778 of those milligrams showed up in the urine. Okay? But at the vegetarian diet, even though the 800 milligrams was still in the can, in the body, only 416 came out. So there are only two possibilities here. Either the absorption from the gut was much less when the phosphorus is in complex with vegetable, and that's why you're seeing a lower excretion, because it didn't get absorbed. Or you're seeing this because it got absorbed, and all of a sudden it stayed in the body. So the question would be, if this person was in positive phosphate balance, then you'd say, yeah, this is the reason for the low number. Their skeleton took it on.
Or fecal.
Yeah. So you have to have the fecal measurements to see,
To know.
Yeah. And is this fecal?
No. Is it? I think it might be. Yeah. Let's see. Urine 24-hour.
And then this fractional excretion of phosphate.
Yeah, fractional excretion.
Okay. So anyway, what we need is the fecal.
Yeah.
Like Fuller Albright, man. He got his hands dirty.
Right.
So that's why he's awesome.
But if you think of that in terms of maybe the other way to reflect
we don't have but do we have the survival of these people?
Yeah, no. This was a short, quick thing.
Well, no, but it's 10 years ago. So has somebody done the study big enough with controls where instead of crossing over, you can't cross over the people if you're looking at survival.
No.
And what I would want to see is the follow-up, the natural follow-up of, now we've said that vegetables different.
This randomization didn't last that long.
Now let people eat what they eat.
Right.
But the ones that subscribe to the vegetable.
Right.
Let's follow them up. Maybe it's going on.
One thought on this one is that on the plant-based diet, your FGF23 levels are lower, so you're less phosphaturic.
Right.
And that would reflect why the urinary phosphorus went down.
That's right. But where else? Where's all the other?
Then it's not.
We need the balance study.
Right.
If you ate 800 milligrams,
where did it go?
We know it's in the urine. We know some's in the urine. We know some's in the fecal.
Right.
Whatever you took in, if all 800 milligrams got absorbed.
Right.
So it must be that fecal plus urine equals 800.
Right.
If fecal plus urine doesn't equal 800,
then you're in a positive balance.
Then it's in bone.
Right.
And that's the number.
Or somewhere else.
So that's the question. Do they have those numbers?
Right. That's a good question. Yep.
I mean, my job is to try to ask good questions.
From everything I've looked at related to phosphorus, it's one of the reasons I eat very little animal protein, and I try to be on a mostly vegetarian, vegan diet, and that's mostly to do with phosphorus and Klotho and FGF23.
Right, and I'm a deeply closeted vegetarian, as I mentioned. So, to prevent anybody from noticing, I eat a lot of meat. Okay,
you're a pseudo-vegetarian.
Pseudo-vegetarian. So, what is the cause of this mortality? And what we've done is, again, is it the elevated phosphate that we see goes along and associated but not necessarily causal to the survival? Is it the elevated PTH that we've treated so aggressively? I mean, clinically, this is what we've done. Binders. Low phosphate diet, binders, low phosphate diet, binders.
Right.
PTH, binders. Cinecalcet, blah, 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 blah. And now we're trying to target FGF23. Is it one of these three? Is it some of these three? Or is it something else? So let's look at the possibility.
Okay.
So I love this picture. I'm using this with permission of the artist, very talented artist. And what these show, these are the Moirai, or the Fates. These apparently are the daughters of Zeus.
Right.
So in Greek mythology.
Except they're often hags. These are very beautiful Fates.
I know. I mean, I don't know if they're hags. They're just not beauties.
Yes, that's true.
You got to remember, when you say to somebody Cleopatra, what do you think of? Who do you picture when somebody says Cleopatra? There's only one person I picture.
All right, let's hear it.
Elizabeth Taylor.
Right.
Now, Elizabeth Taylor, not a hag.
Not a hag.
Not a hag.
Pseudo hag.
I mean, if she's a pseudo hag, she's doing really so. She is obviously an icon of beauty.
Right.
But have you ever looked at the statues of what the real Cleopatra looked like?
No, I haven't.
She ain't no Elizabeth Taylor. She ain't no Elizabeth Taylor.
That's funny.
So yeah, you're right. So the Moirai in the sculptures of them are not. I wouldn't say they're goddesses,
right?
Although they are,
but they're the daughters of
Zeus, apparently,
right?
And so there's 3 of them, and this was this goes along with the myth of how long do people live.
Right.
So there's 3 Moirai, 3 fates.
Okay.
The one that spins the thread of life is referred to as Klotho with a C, and sometimes Klotho with a K. She spins the thread. There ain't no life if she's not spinning it. So she's spinning the life here.
Right.
Spinning. Then this one, I hope I'm pronouncing it right. You pronounce it, so I don't have to make a mistake.
Lachesis?
Lachesis. Okay, fine.
I'll take it.
Lachesis. She measures out the thread. And then here's the one that decides when it's all over.
Right.
So there's the how long you live depends on how much Klotho is going to spin out. And when Atropos decides to cut it. And I always wondered if atropine was named after this. So anyway, she cuts the thread of life. And so she is with her scissors, royal scissors.
Right. I love it.
Okay. So these are the beautiful Moirai.
Right.
And so Klotho basically is the one who's she's the star of the show here, because she's the one who doles out life and longevity in the first place. Even though one's measuring it and one's cutting it,
right,
she's the source of the life.
Yes,
Okay.
I see that.
Okay. So again, used with permission of this beautiful artist. So then something happened in 1997 that changed my life when I saw this paper come out in Nature. And this is Nature, not open access.
Right. This was
before open access.
Right.
So Makoto Kurao,
yes,
who is the most well-known name in the field,
yes,
published a paper in Nature that says mutation of mouth Klotho leads to a syndrome resembling aging. So what happened here is
he was in Texas, wasn't he? I think he was.
I think it was in Japan.
Oh,
I mean, every
maybe.
author.
Yeah,
here,
you might be right.
I don't see any Texans here. I don't know how many cowboy hats would have here, but I think it was from Japan.
Okay,
from Japan. I mean, there have been extensive collaborations with people in Texas, and stuff like that since then. But this is original work. This was the first paper.
Okay,
and to me, this was a game changer.
Right.
Now we got a hormone or some sort of protein.
Yeah, gene.
That's affecting aging. Yep. And this was a mistake. So just like when Peter Agre pulled chip 28 out of the freezer, he was studying eye disease or hematology.
Red cells.
And all of a sudden they found aquaporin 1.
Right.
And he won the Nobel Prize for that. So he'd be the first to tell you. I remember him coming to Yale and telling us, yeah, I found this thing in the freezer, chip 28. I got the Nobel Prize for it. So this one is also a serendipitous discovery. They were playing with some genes and they did this knockout. And what they found was, and again, these Nature abstracts are beautiful. I think that basically they were the tweets before there was Twitter. Because if you did something beautiful, you only need a couple sentences to say.
Right.
And the usual Nature abstract is, here's what we knew. Here was the problem.
Here's what we did.
Here's what we did.
Yeah, it's short and sweet. They're beautiful.
Yeah, beautiful. And here's another one. So you just take some short time to read. Go ahead and read it, Craig.
Yeah, let's see.
I've read it a million times.
A new gene termed Klotho has been identified that is involved in the suppression of several aging phenotypes. A defect in Klotho gene expression in the mouse results in a syndrome that resembles human aging, including a short lifespan, infertility, arteriosclerosis, skin atrophy, osteoporosis, and emphysema. The gene encodes a membrane protein that shares sequence similarity with the beta-glucosidase enzymes. The Klotho gene product may function as part of a signaling pathway that regulates aging in vivo and morbidity in age-related diseases.
Right. And so this was gigantic, I thought, because these mice not only died fast, they looked old. Wrinkled skin.
It was like rapid aging.
Rapid aging. So here was the main finding of this paper. That
97.
That here's the normal lifespan of a mouse who had normal levels of Klotho. And they did two things. The knockout was living
80% shorter.
Yeah, 20% of the lifetime.
Wow.
Than the normal mouse. And then they did the beautiful thing where they gave extra Klotho to a mouse, and it lived longer.
30% longer.
Well,
that's a long life.
That's a long life. And I mean, it could be that Paul Rudd had lots of Klotho.
Right.
I mean, This ain't
He's
Paul.
an overexpresser.
This mouse is not
He's
named,
so expressive.
this
I'm sure he's expressing more close.
This mouse is not named Paul Rudd.
That is not Paul Rudd.
This is Paul Rudd.
That is.
Okay? And, you know, I hope that I know he's not a viewer because he'd be calling.
Right.
He's not a viewer.
No.
I really think, Craig, that use your connections.
We need Paul Rudd to watch this.
I would like to measure his Klotho level.
I think you should.
I think his Klotho levels may tell us something. But this is a major finding.
Do you think Klotho levels have something with number of nephrons?
Yes.
Okay.
Yes. Because guess where the first thing I wondered about was, okay, this Klotho thing. Who makes it?
Right. Who makes it?
Who makes EPO?
In the kidney.
Who makes Klotho?
In the kidney.
You betcha. Who
Red
makes
cells.
renalase? In the kidney.
Right.
All these things are lost in a dialysis patient.
Right.
So, or somebody with bad kidney. So this was huge. I leave this up because I think this is a huge, huge finding.
Well, it's funny because even in the Far East, when they would talk about aging, they talked about you losing your water in our body and we dry out and fibrose and scar
raisin.
down. And that this was all regulated by the kidney. So they felt, even because I remember some old slides and stuff that I had used in some old talks, looking back at what they talked about with aging and those things, and it all came back to the kidney.
Well, I mean, I think that, you know, we're always biased to the kidney.
Right.
So I need proof that it's I'd love to think it's the kidney.
Right.
But I need some proof. But anyway, again, I think Klotho is gigantic, and I think that Paul
This
Rudd's
is
got a lot of it.
amazing data.
Yeah. Now, this is
But one thing that's
1997.
very funny about this is that the Klotho knockout mouse looks exactly like the FGF23 knockout mouse.
Well, I think there's a reason for that. I mean, maybe somehow or other they interact.
But FGF23 knockout has Klotho.
Right. But here's what it turns out. So a few years later, 13 years later, here's a parathyroid cell. So the parathyroid cell's got everybody. Not only does it have the calcium sensing receptor that also senses phosphate,
Right.
but it turns out that it's got a receptor for FGF23.
Right.
And that it's got Klotho.
Is
So
it FGFR1 in the parathyroid?
Yeah.
Yes. Okay.
Yeah. So it turns out that Klotho is in the kidney. So apparently the receptor is more in the distal nephron, but it certainly has its actions in the proximal tubule as well. It's found in both. But of course, NAPI is found in the proximal tubule. But one of the first initial discoveries was that Klotho had a co-receptor, and FGF23 was the co-receptor. So there's soluble Klotho and there's membrane-bound Klotho. The membrane-bound Klotho has associated with the receptor. So, one of the feelings is that the parathyroid gland becomes resistant to FGF23. In other words, FGF23 levels go up in CKD and they try to put the brakes on PTH. But if the parathyroid doesn't listen, there could be, because these hyperplastic parathyroid glands lose their ability to respond to FGF23.
So they think there's some compensatory impact on the parathyroid cells,
right,
in terms of FGFR
until the parathyroid cells escape, until the hyperplastic cells escape from regulation.
Right.
Right. That's one of the things hyperplastic cells do. They escape from regulation. So
does early on, I wonder if PTH goes down at all early on?
Well, I don't think it does, but let's just see.
Because if there's
it's Klotho FGF23 signaling in the parathyroid is aimed to decrease PTH.
Right, exactly.
And so it depends on the frequency response of how
who gets more of a sensitivity.
Right, and who's making, and how often are you making your measurements?
Right.
I mean, we don't make these measurements.
No, of course not.
Once a year, once every 6 months, not going to pick it up. So let's talk about FGF23 for a second.
Okay.
Because these are together.
Yeah.
So FGF23s are produced by osteocytes, making it clear that the bone is an endocrine organ. FGF23 has multiple effects, and Miles has lined these out for us. Parathyroid, again, to inhibit PTH, again to inhibit the 1-alpha hydroxylase, as we said several times now, opposite of PTH, and again in similarity to PTH, inhibits the NAPI in the proximal tubule leading to phosphaturia. So PTH is phosphaturic, PTH, phosphaturia, but so is FGF23. And the question is, why do we need two phosphaturic hormones?
Right.
Okay. Now, they have a little difference in the way they affect
the 1-alpha.
1-alpha. And Klotho is also the co-receptor for FGF23 in the kidney.
And when I asked Miles, I sent him that email and I asked him that question, why should both of them be phosphaturic?
Yeah.
His feeling was that if Parathyroid wants to be purely managing calcium, then when the PTH comes out and, your vitamin D stimulates reabsorption of both calcium and phosphorus, then as the PTH goes up, it would cause you to get rid of the phosphorus and keep the calcium up. So it would be kind of this net just positive calcium as opposed to...
Right, but if the PTH is being phosphaturic, what is FGF being phosphaturic on top of it do?
Right.
Because it's also trying to inhibit PTH. So PTH is trying to be phosphaturic, but FGF is trying to inhibit PTH.
Well, the point is that PTH is only being phosphaturic when it needs calcium.
So maybe there's
different pathways.
Maybe there's a balance between
you didn't take in a phosphorus load when you called for PTH. You called for PTH because you had a low calcium.
Right. So maybe there's in the steady state when both of these levels are going on, they're basically playing off each other.
Yeah.
So the other regulators, increased ECF phosphate, which we now know if the calcium receptor sensor is doing something, is trying to turn on PTH. This also stimulates FGF23, so driving both of them up. And PTH stimulates FGF secretion, but FGF secretion negatively feeds back. So there's definitely a yin-yang PTH FGF23 axis.
Okay.
So this is the parathyroid, this is bone, and they're talking to each other.
Right.
So here's again Frontiers in Endocrinology review from 2016, physiologic actions, just to review the physiologic actions of FGF23. So here again, you get one of our, look at this. Now, I can't read this, so I'm going to let you read this.
Oh my God, that's so hard to read. Yeah. You mean in the table there?
Well, I mean in the box. So, this is very recent. This is only, not even a year and a half ago. And again, what do we got here?
I can go down from the top and you point and let's go through it.
Here we've got first of all, here we got the gut.
So they start with phosphorus. They say higher dietary phosphate intake, reduced phosphate excretion increases serum phosphate. That's number one. Okay. So that makes sense. And then they say FGF23 secretion and PTH is stimulated by a high serum phosphate.
Right.
Okay. Then they say PTH is stimulated compensation by low vitamin D.
Okay, because
FGF23 is inhibiting the 1-alpha.
Right, and PTH is trying to work against that.
Right. FGF23 decreases phosphate reabsorption and increase excretion in urine, thus lowering serum phosphate. Then they say FGF23 suppresses PTH and vitamin D formation in the kidney.
Right.
Vitamin D can increase phosphate absorption in the gut and indirectly phosphatemia, FGF23 secretion.
Right. So what we have here is a new player is added and we have more eras.
Yeah.
And yet, we still, again, they started phosphate, but we still don't, and then what they added here, there's two things that are added to this diagram versus the first one of these that I showed.
Right. They add Klotho and they add EPO and anemia.
Right. They had Klotho, FGF23, and EPO and anemia.
How many times have you seen a patient with a high parathyroid? No, I'm just kidding. I'm just joking.
Once.
I had a patient with his PTH who had totally uncontrolled hyperparathyroidism. We could not get his hemoglobin above 8. He felt terrible. He was a home dialysis patient. And his PTH, he'd been on dialysis for years in the setting of PKD. And his PTH ran 2,000, 2,500 on max and a Calcet. We had him on everything.
So he must have parathyroid hyperplasia or islands.
Right.
Did he have tertiary?
But he had severe secondary hyperparathyroidism.
How do you know he had some tertiary?
Well, he was on dialysis.
Pseudo-secondary.
So he had pseudo-secondary. Yeah. But in any case, my point is that we parathyroidectomized him and he needed calcium supplementation and his anemia resolved. All of a sudden, I had to back his ESA therapy down significantly because his hemoglobin shot up.
Would that be predicted by this slide?
Right. That's my question. It's hard to know because it seems like it's mediated by Klotho, but it didn't change his Klotho expression.
Right. But you also mentioned that
his PTH
Well,
went
it
way
changes
down.
Klotho axis in the sense that there's Klotho receptors in the parathyroid, and those are now gone. And you had also mentioned.
So I removed Klotho.
Right, you removed a little bit, but maybe it was in a bad place. And then you also mentioned that we know there's interactions between FGF23 and iron.
Right. Yes.
And maybe it doesn't show up as an iron deficiency anemia classically, but maybe it still affects. I mean, bone. I got to say, when somebody's got huge PTH levels, there's a good chance that bone's not happy.
Right. Yeah. I mean,
and bone is where
that's for sure.
Maybe there's EPO resistance. I mean, you were giving the patient.
That's what I'm wondering. I'm just questioning,
EPO,
like,
right?
yeah, because we know that people say this. Secondary hyperparathyroidism makes it hard to manage anemia.
Yes.
I mean, that's out there. We know that.
Yes.
And the question is it the PTH? They don't have any arrows from PTH to anemia, EPO, Klotho.
No. They've got it. Yeah, they've got it from EPO and anemia. They don't even have iron on there, but Klotho is doing something.
Right. So that's my question is I'm trying to put that together, but I'm not seeing it fitting in this diagram, how I could explain that
again,
from
just draw,
any arrows
you know what you should do? Get a marker. No, get a marker out and just draw another arrow.
Yeah.
And no one's going to ever notice, Craig.
They won't notice. I can slip it out. You know who does that? Trump does that, doesn't he?
Put another arrow in.
Just throw an arrow on there.
Sharpie out and put another arrow.
No political stuff on here. Sorry about that.
But yeah, just get an arrow. Just get a Sharpie. Get an arrow.
Get a Sharpie.
But the thing is, it still shows us. It still shows us that you don't want the new player. See, I don't want the new players to just come in and add arrows, because that just makes a complex diagram more complex. I want the new players to give us insight.
Well, we want the arrows to be truthful. I mean, we want to see the truthful.
Yeah, and we want to know which one
meaning.
comes first. We know if they're all black arrows,
right.
we know the negatives and the positive. We don't know which are the primary and the secondary.
But I like these guys because these guys walk us through what they're saying.
Right.
And they were very nice to do that, because if they just put this with no text, that would be a challenge.
It would definitely be a challenge.
But they start with phosphorus, and then they go to FGF23.
And they make it FGF23 centric, which is fine.
Yeah. And then just the last little section, they say PTH promotes FGF23. And then they say anemia, hypoxia via HIF, trigger EPO release in the kidney. EPO promotes expression of alpha Klotho.
Yeah. So, I mean, anything's possible. There's an old saying in mathematics, give me 4 exponentials and I'll fit an elephant. So we know that you can make it fit, but it doesn't mean that it's descriptive. It's descriptive, just like 4 exponentials can fit any function.
Okay.
It doesn't tell you what the function is really doing.
Right.
Okay, so here are, I'll let you take this one, because this goes along with you and Miles' discussion about the FGF23 dependent disorders, and here's our favorite one.
Yeah, okay. So these are the disorders of FGF23. So hypophosphatemic disorders, right? Hereditary X-linked hypophosphatemic rickets, autosomal dominant. These are all the primary excess FGF23 disorders.
Right. These are the non-CKD primary.
So right. So just like any endocrine disorder, you can have a primary disorder where the hormone's dysregulated and just secreting, or secondary where it's responding to some signal. It's being called for and responding appropriately.
Right. So these are the primary FGF23 disorders. So these CKD is a secondary.
Right. So these osteoclasts are dysregulated.
Right.
So the X-linked hypophosphatemic rickets, ADHR, autosomal recessive hypophosphatemic rickets, and the acquired disorders, and the tumor-induced osteomalacia. Yep. Right.
And these FGF23 disorders many of them have got to be associated with Klotho because they're co-receptors.
Right.
Okay. So let's take a look at this. Is again something that came from Miles.
There's Miles' shoulder there.
Yeah, Miles' shoulder. Oh my goodness, we got Miles' shoulder.
I love it.
So this was a picture. So Miles
he wouldn't let me show his face. He gave me approval for the right shoulder, though.
Okay, so Miles is giving a talk.
Yes.
And you're listening to him.
Yes, it was a virtual talk.
You remember what year it was?
I think this was 5 years ago. I think this was like 2016.
Okay, so you like this slide. It's got iron on here. What does this slide tell you?
Well, I like this slide because it breaks this down into it.
Wait a minute. This is a shocker. Miles put FGF23 in the middle.
There's a tablet. It's the FGF23 pill.
Yeah, it's a pill.
You don't like that? It's
like
scored.
He puts it at the center of the universe.
He does.
Okay.
It's the center of the universe.
What do we got? Let's take the deficiencies first.
Okay. So on the deficiency side, if you have a primary deficiency, that's tumoral calcinosis, or if you ablate FGF23 production, you get severe hyperphosphatemia, makes sense, high 125, right? and low biologically active or undetectable FGF23.
Right.
And then if it's a secondary FGF23 deficiency, that's a low phosphorus diet, makes sense, vitamin D deficient, vitamin D receptor deficiency, 1-alpha hydroxylase deficiency, NAPI deficiency, or some deficiency in NAPI2C.
Yeah, so again, you see Klotho and all of other hormones showing up here. So these things are inextricably linked. I mean, FGF23 has now gotten into the mix.
Right.
But
But
mix
one is
still
the
same.
osteoclasts are doing the right thing, and one is that they're doing, which is secondary because they're responding to something, and the other is that there's something wrong with the osteoclast, either a gain of function or a loss of function.
So you see pseudo hypo FGF deficiency.
I'm not sure, but in the excess
Let's look
group
at the
here,
excess group, the primary.
the primary, that's the autosomal dominant.
These people don't have kidney
rickets,
disease,
right? Yep. And those diseases lead to severe hyperphosphatemia, inappropriately low 125D, and a high FGF23.
Well, it's people that give a bunch of intravenous iron. What's this telling us?
Yeah, I mean, iron, there is some relationship to iron and how it impacts the cleavage of the FGF23 molecule.
Okay.
So
just to make it a little bit more complex.
Well, what's funny was the way they figured this out was, I believe, and I'm not positive, but I think it had to do with the autosomal dominant hypophosphatemic rickets.
Yeah.
These people could flare. If they were iron deficient, there could be a flare up of hypophosphatemia.
Yeah.
But then when you repleted their iron, they wouldn't have it as bad. And so it had to do with something in how they cleaved, in the availability of their FGF23 molecule. So those people make this super FGF23 molecule that can't be cleaved, and iron deficiency causes you to make more. But if you can cleave normally, if you get iron deficient, you make more FGF23, but you cleave it, so it doesn't matter. You've disabled it.
Right.
But if you're iron deficient, you don't cleave it. I mean, if you have this disorder, you don't cleave it, and the iron deficiency pumps up your FGF23, and that's super FGF23, so they get very hypophosphatemic. So they can have these flare-ups. So there's some connection with iron deficient, with iron regulating your FGF23 production.
Okay.
Right.
So now we've got,
and then secondary.
Yeah. That's where I.
And this is our world. And when you look at the world, the CKD section and this secondary hyper FGF23 emia that's the biggest public health section. I mean, this is the big segment.
Yeah, these
here.
are rare.
Right, those are rare, and this one is big.
Right.
And CKD, high phosphorus diet, and I believe in that even in the people with normal kidney function, and Klotho deficiency, people born with fewer nephrons or one kidney, and those types of things.
We'll have to ask Miles what kind of diet he eats.
Yes. He always talks about a palatable diet.
Palatable.
I've eaten out with him in the past, and it's pretty normal, I bet. But he's very focused on wanting to fix things so that people can eat a diet that they like.
And it's nutritious.
Right, because look, we can all come up with these diets that are probably the best diet for us that are miserable and not palatable.
Well,
and we all are connected to food.
Right, well, there's an old saying, if you want to live forever, don't eat.
Don't eat.
So here is the man himself, the maestro, who cloned Klotho. Publishing in Nature Reviews Nephrology in 2019, just a couple of years ago, a real great review. This is a great review on Klotho proteins in health and disease, and this is there's a bazillion references in this paper. So I mean, and the whole world's collaborating with them, including people in Texas. So here's the slide that was one of our first opener, and FGF23 inhibits NAPI and PTH, and
1-alpha
hydroxylase. And so again, here he starts off with phosphate intake. Again, he's not talking about in this recent paper the calcium sensing receptor being the phosphate sensor, but these calci protein particles. And then here is again gets right into the loop, not the loop of Henle, but the loop of FGF23 and vitamin D and PTH. And according the reason this is featured is, of course, alpha Klotho, which is the membrane-bound form that associates with FGF23, is in the parathyroid and the kidney.
You sure that's not a horseshoe kidney there on the left?
I thought it was until I saw parathyroid.
Then he labeled it.
And then, so there's phosphate intake and at least the phosphate excretion, and there's these guys in between. And you see FGF23 affects the kidney, both the phosphate transport and vitamin D expression. And then there's this back and forth where PTH stimulates FGF23, but FGF23 negatively feedback on the PTH. But we've got the players here, and that these are the calcium and phosphate players. We can all agree that this is calcium phosphate world.
Yes.
So what he shows here in this picture,
and that was what I was going to say. If you go back to the first one, the part of the axis that's missing here is where else can this calcium and phosphorus go, and it's the blood vessels.
Right.
So I kind of feel like it's
deposition.
Yeah.
Well, it can also go to skeleton.
Kidney, bone, vascular access.
Right. Right. But again, is the gut, the bone, parathyroid, the kidney.
Right.
So here's the vasculature.
Okay.
And of course, we know there's the blood cells flow in the lumen, and then there's the endothelium, the vascular endothelium, and then there's on top of the vascular endothelium is the vascular smooth muscle, and it's a smooth muscle where ossification, calcification, and stiffness comes in. This would be arteriosclerosis,
right?
Hardening of the arteries. Calcification of the arteries. So you notice in this picture, he immediately has two similar colored boxes, CKD and aging,
right?
As if they're separate,
right?
But they both impact nephron number and
FGF23.
What happens to FGF23 levels,
right?
And that when you eat your phosphate, this happens. There's some sort of sensor, and in here he's got this sensor versus the calcium sensing receptor, and these particles do not good things. They lead to inflammation and damage.
Are these the same calciprotein particles that people are saying are the regulators that were the sensors?
Yeah.
Right.
Yeah, it's the same. It's the same as these. The gut absorption into CPP's question mark.
Right. Go to bone.
Yeah.
Okay.
And this is happening in the blood vessels.
Yeah.
So that's not good because this is, of course, the end organ that maybe everything needs a blood supply. And if the pipes are, the pipes are failing. It's Klotho boy. Oh, Klotho boy, the pipes. So here is a slide that's too hard for me, so I'll let you do it. And it basically shows the membrane, the alpha Klotho. There's multiple forms of alpha.
Yeah, so they're soluble and membrane bound.
Right. So the membrane bound has this kind of genetics coming off the exons from the gene, and then there's a soluble form. Right. And the soluble form was apparently not detected in the blood. And then there's what's happening at the level of the kidney. So this is what we're more familiar with. We got soluble Klotho and membrane-bound Klotho, but that FGF23, as well as FGF other things, are associated and sets off signaling processes. And that it involves a bunch of growth factors. So all of a sudden now we're starting to see, well, how does Klotho maybe affect aging? I mean, look at these are inflammatory markers and growth factors and everything up to the ion channels. I mean, the pump.
Right.
I mean, you got to have the pump and channels. There's a calcium channel. There's a potassium channel. There's the pump itself. There's another TRIP channel. All of our favorites. We've talked about TRIP channels, Nobel Prize winning channels. We've talked, and they're involved in calcium. This one's involved in
potassium.
FSGS. This one's involved in FSGS, which is a vascular disease, right? It's glomerular. So here we got calcium. Here we got another TRIP channel that's vascular. Here we've got a K channel that's very important. Here we got the pump itself. Here we got phosphate transport. Look at all this stuff.
Right.
Okay.
Yeah.
And so this is, so Klotho is right in the mix. It's in the mix of everything. So here's the FGF-Klotho endocrine system diseases. There's the hormone FGF19, which apparently associates with beta Klotho in the gut. And this has to do with some sort of metabolic responses. And there's disorders. They have to do with cancers. Cancers will make your life shorter. Then there's FGF21. We knew that we all heard a lot about FGF23. We knew there'd be 22 others.
Right.
We never talked about anything. FGF21 is also in the liver. It also associates with beta Klotho and does these similar kind of things. And here you got diabetes and obesity. So these are the things that are killing people. Okay, this is bad. I don't know if bad stands for bad or stands for something else, but bad is bile acid diarrhea. Well, that sounds bad.
Yeah.
Sounds bad. But then here's us in the red oval here is FGF23, which is bone. Miles would agree with that. And the target organs are the kidneys and the parathyroid. This is alpha-Klotho, and this is associated with FGF23.
Right.
And this is our phosphaturia and our vitamin D and our PTH.
Regulation.
And look, the regulation, the disorders are when you have CKD is the biggie here.
Right.
The people that we care about.
Yeah.
I mean, not that we don't care about other people, but the people that we see and the people that is common. So
what's funny on this slide is that like CKD is the disorder. They go together, but the primary thing is Klotho deficiency.
Let's have a look.
All right, let's go.
Let's remember.
Yeah, I remember the slide. Yeah.
Call back to this slide.
Call back.
Now what we're doing is we're saying, of all this other stuff we've talked about, I mean, there ain't even a flat part.
Right.
I mean, your Klotho's flat when you don't have CKD anything. So as soon as you got CKD anything,
right.
And we don't see this because we're not great at measuring it. We don't even know if they measure it in blood, whether that's the measure. Because again, some of these things, soluble Klotho is not so easy to measure. I mean, it's measurable,
right?
But the thing is, one way to make it go up is to give it,
right?
Okay. So Klotho is going down. So this brings me to look at some other data. So let's just look at more papers. This one's from what is that? 2020. 2021?
2021.
Right.
Yep,
so
October.
Here's some mouse data. Klotho overexpression protects kidney aging.
Right.
And it's affecting TGF beta. So here's just their wild type mice dying or survival curve. And then here's the Klotho overexpressors. They live longer. Not only do they live longer, they got better looking kidneys. So they got the Paul Rudd.
Yeah.
Okay. So this is Paul Rudd. This is
right. Look at that tissue. You don't see any fibrosis in there.
This is PRK, Paul Rudd kidney.
Right.
So here's the young mice of both types. Looks fine. Then the wild type has got some blue.
Right. A little fibrosis in there.
Paul Rudd kidney.
Right.
So that's why I really want to know Paul Rudd's. Have you gotten them yet, Craig?
I put a message out.
I
got my people talking to his people. Miles definitely knows Paul Rudd.
Oh, that's no doubt about it. But these look like young kidneys.
Okay.
So they're living. The kidneys are living longer, and the mice are living longer. Now look at this. What else does Klotho do? Klotho makes better medullary fibrosis, and look, our old friend, Pressure-Natriuresis in hypertensive rat kidney. Let's take a look. This is hypertension 2018. Let's take a look at this. So here's what happens when what Klotho does. So Klotho lowers plasma angiotensin II levels. But that's already going to affect pressure-natriuresis because we know that that's going to affect the GFR hemodynamics we talked about. Okay, so lowering your angiotensin II levels is going to lower blood pressure,
right?
Possibly. It lowers angiotensin II in plasma. Klotho lowers angiotensin II in kidney, and Klotho lowers the angiotensinogen, which is the precursor, in kidney.
Okay.
And then here, Klotho levels in the kidney, Klotho levels in the plasma. These are the mice. So the Klotho mice had more Klotho in their kidney, more Klotho in their plasma, and more Klotho in their urine. And they're living longer with the better Paul Rudd kidney. Okay? So, and here's what I love. So here's the effect we would expect.
How are they giving Klotho here? Are they?
It's genetic.
Yeah, okay, it's genetic.
They got a genetic overexpressor.
Overexpression.
Yeah, they're overexpressing it genetically. Okay. They're not infusing it.
Okay, so it's not like a soluble Klotho.
No, it's a genetic. It's a natural. It's kind of the organic way.
Okay.
Not dosing it.
Yeah.
And here, the Klotho mice, Klotho overexpressors have lower blood pressure. Okay, this would make this is the systolic. It's make FDR happy. Lower albumin, and what are the two big deciders of how fast your
lower
CKD
albuminuria, right?
Yeah,
blood pressure and protein in the urine.
Yeah,
that's it. Those are the two big ones.
So I mean, Klotho's doing all sorts of stuff. Now here's the graph I love because it ties right into our pressure-natriuresis talk. They look at renal perfusion pressure versus global GFR. The controls compared to the Klotho have less glomerular hypertension. They hyperfilter less. Those kidneys are going to last longer. And then the piezo de resistance is look what happens to essentially the pressure-natriuresis curve.
It shifts to the right and the slope changes.
It shifts to the left.
I'm sorry. Yes, right. From control
so
to
it
the
shifts
Klotho.
to the left, just like a decreasing angiotensin II effect would have. And the increased slope is like a diuretic.
Right.
So it's almost like these mice are already on an ACE inhibitor and a diuretic. These overexpressing Klotho mice have all these great things happening, and it looks like the Klotho is giving them what I take.
The best therapies.
Yeah, I take losartan and chlorthalidone.
Right.
If I was the Klotho overexpressor, which I hope I am, I wouldn't need that. So this is completely in line with what we talked about with Guytoni and pressure-natriuresis.
Right.
And whether or not it's direct or going through TRP and piezo channels, like we talked about last time, the fact that you're seeing these Klotho overexpressors do this and that from a kidney point of view, man, that's the prescription.
That's amazing.
So isn't that something?
Yeah,
and
that's
luckily,
cool.
I had no idea this was going to happen.
We already gave the pressure-natriuresis. That's awesome.
It killed me that 3 hours and 15 minutes we went. You know, you watch it at half speed, you get killed the whole day.
I went through a whole boatload of Klotho that day.
Oh yeah, yeah. Well, I think that's good for our Klotho.
No, it's actually good for it. Definitely.
So here's again, you talk about the AI data. So here's again humans. Klotho. This is a different study in 2020. Klotho gene in human salt-sensitive hypertension, another pressure-natriuresis curve, showing that's affecting salt-sensitive hypertension. And what they're trying to say, again, these are hard to measure, but what happens when you plot how much alpha Klotho you can measure versus mean blood
against
pressure?
pressure.
There's some, I don't know how they get this line, but
I love these scatter plots.
It's a scatter plot, but they're trying to make the point.
Yeah.
That the more Klotho you got, the lower your blood pressure, and that goes along with.
I'll go back to that slide for 1 second.
That goes along with this.
Yes.
This, and this.
Right, but you definitely get the sense that as the Klotho level goes up to the right on the x-axis on the right panel, that you're not seeing any high blood pressure readings in that group.
Right. I mean,
so you see that.
Yeah. I mean, this is again, these are late breaking.
Right.
You know, we're not even February yet of 2022, and but this is translating to human. Now there may be some studies where Klotho doesn't work, but the measurements are hampered. We're not good at measuring them, and this is not these are not it's
circulating alpha Klotho.
They're looking at Klotho polymorphisms. They're looking at but it's making the point that blood pressure, which we know is directly, that's right in our wheelhouse. Klotho is involved.
Right.
Okay. And with pressure-natriuresis.
And it makes sense from what you said before in terms of the ion channels that Klotho is involved with.
Right. Exactly. So is Klotho too good to be true? It's a question we got to ask now. What does it do? And is it too good to be true? It secretes phosphate in the urine. Love that. Except if you're eating, it's a good thing. Lower systolic blood pressure and angiotensin II, having those effects we just showed on pressure-natriuresis. Shifts the pressure-natriuresis curve to the left and increases the slope. You got to love that. And what do you have today? Give me a left-shifted pressure-natriuresis curve with an increased slope.
As a throw out to Miles, I would say Klotho excretes phosphate in the urine in the presence of FGF23.
Yeah, because they're co-receptor. Right. It's not a throw out. It's that's what happens.
Yeah.
It lowers glomerular pressure in albuminuria. How great is that?
Mm-hmm.
Anti-inflammatory action downregulates NF-kappa beta and suppresses tumor necrosis factor, and TGF beta. It protects against vascular ossification and CK-MBD in data I didn't show, but it apparently does that.
Mm-hmm.
It mitigates renal fibrosis by suppressing TGF beta 1, the Paul Rudd kidney. Appears to help, and there's data from neuroscience folks. Definitely. I've heard talks on this. I've heard TED Talks on this. That Klotho levels correspond to higher Klotho. The more your Paul Rudd, the less likely you're going to develop dementia. So that is huge.
Yeah.
It helps slow the progression of CKD. it slows aging. So essentially, since I saw this paper in 1997, I said, okay,
they're going to come out with a Klotho infusion.
If Klotho is made by the kidney and modulates transport and affects divalent ions, they're tied into aging. And basically, when you lose your kidney, you lose your Klotho, and CKD is Klotho deficiency, and CKD is aging. And I ain't never seen a dialysis patient that looked better than they would look if they weren't on dialysis.
It makes the point of why transplants are so important and what's missing in dialysis. What's missing in dialysis is giving people Klotho.
So again, I only have one kind of hypothesis slide. It's got a red box, a green box, and a blue box.
This is a standard Allen.
Standard Allen. So here are some alternative hypotheses.
Okay.
And, Miles might have his favorite. You might have your favorite. I might have neither one of these could be right. I'm just saying it's one thing I think about. So the red boxes are the disease, okay. AKI, CKD, and ESKD. We got both of those.
Yep.
The green box are the mediators. So let's say all you need to, let's go to the bottom first. So let's say you got AKI, CKD, ESKD. We've spent a lot of time here, all the time, showing how this increases FGF23 and PTH levels.
Right.
It increases phosphate. And we've shown how those give you cardiovascular disease, accelerated aging, and early death.
Right.
And of course, there's this going on. Okay. The question is it this three-way pathway to the anti-Paul Rudd effect? Or is it really just take this? You got this, which gives you this, which gives you this, and that these are epiphenomena that fall out of these.
Yeah, I see what you're saying.
So I don't know if either one of these is right, but this is the way I think about it now. There's a lot less arrows here.
Right. One of the things I wonder about is do people with hypophosphatemic rickets who have the severe elevated FGF23 levels get severe LVH? Because one of the questions...
If we left them untreated.
Right.
I mean, those people, the thing about those people is they're young at discovery.
Right. They're young.
They're young. They haven't really aged much.
Right.
And they could probably, they're at a point in life where they can undo their aging.
Right.
And, I don't know what happens if you leave them untreated. Somebody tells me they fall apart.
And I'll give you an example. One argument why FGF23, and these are good for discussions because we don't have the answers to these things. But for instance, this recent study, a small study in dialysis patients that looked at LVH in people treated with, etolcalcetide.
Yeah.
That if you give them, you can reduce their FGF23 using etolcalcetide. And the people who got that medication versus calcitriol had no progression of any LVH measured by LV mass.
What happened to their Klotho levels? We don't know.
Well, the thing is they're on dialysis.
Okay.
So they have the same Klotho they had before.
Maybe.
I mean, I
don't know.
Is there more to it? We can modulate our Klotho production, in ESRD?
I don't know. Kidney is a big source of Klotho, but it's also on the parathyroid. I don't know.
Right.
But, I like less arrows.
Yeah.
And I like mechanism. Mm-hmm. And again, Klotho, with the data that we've seen now, it's fundamentally different than any of these. These are hormones.
Yes.
This is an ion. These are hormones.
Yeah.
These tend to react. Like again, PTH.
Well, they adapt and then they maladapt.
Right, but the point is the boss of the parathyroid is the calcium sensing receptor. The output is the hormone.
Right.
But the boss of that is the calcium sensing receptor. You fool with the calcium sensing receptor,
it's going to screw it up.
Right. So that would be the green box. Okay. So here, in this kind of red, green, blue slide for me, calcium homeostasis would be calcium sensing receptor here, and then this. It's the boss. So there's a lot less arrows here. And the question is this hypothesis. And so, again, like people say, this is what's going on. Prove me wrong.
Oh, okay. I think that's a good point. One question would be, number one, Klotho can't work alone. So I don't think you're wrong. I think this is right. CKD is Klotho deficiency.
And it doesn't work alone. It's doing too many things.
The reason we know is that if you leave Klotho intact and you knock out FGF23, cardiovascular disease happens.
Yep.
The same thing happens.
Yep.
So in the presence of normal Klotho.
Yep.
Unless we can show that the Klotho goes down. But my point is,
but the original study showed, you knock out Klotho from the mice.
Right.
They're finished.
And the same mice, you knock out FGF23, the mice look identical. You can't tell them apart.
Right.
That's how they actually figured out that they were co-receptors.
Right.
Because the phenotype of these two knockout mice look identical.
But the FGF23 level is different than the FGF23 receptor. I mean, the co protein for Klotho is the FGF receptor. But the hormone-ish thing made by the osteocytes is FGF23. So I mean, that's the thing it binds with.
Right.
So again, this is the easiest way of thinking about it. And so since it's the easiest way to think about it, I mean, I wish we had Fuller Albright back on the phone.
We need him.
Sort of say, okay, Fuller, you published your 1938 paper with that saying, look at this, it's confusing. And then he looked at all the confusion that caused. And for years we had all those arrow diagrams. This got more arrows than this. I would like to think it's this because this is simple.
Yeah. And I think simple makes sense. I think to me, the way I see it, I'm a little more on the bottom segment because I think I'm with you 100% that
so Craig is here.
Progressive kidney disease leads to Klotho deficiency, and I think that's central for all the things that Klotho does.
Think these are players.
But then I think because of Klotho deficiency, you then trigger FGF23 going up, and you're right that this is a secondary process. It's adaptation to a loss of Klotho.
Right, but this also explains the data because you see, if you just treat this,
nothing
without treating this,
right,
you still get this.
Right.
So that is not sufficient.
No.
There's still no proof that treating this doesn't get you here if you still have that. Whereas the data there's nothing about the data that we know that's inconsistent with this.
Yeah.
Because we haven't treated this yet.
Yeah.
So the thing is, if studies come out where we treat this.
But if you treat the FGF23, there's some evidence.
Right, but that's because it's interacting with Klotho.
Maybe.
Okay. So again, I don't know which one. Maybe it doesn't matter. These are just the way to think about it.
Yeah.
That's why, again, the important word here is hypotheses.
Right.
I'm sure if I submitted it somewhere, it would get
rejected unless you paid $10,000, $11,000.
Exactly. But again, since we don't know, I think the ultimate arbiter of these things, we got to come back to what really is the ultimate arbiter of these things. And what the ultimate arbiter of these things are, and we've talked about it in multiple podcasts, is what's going on in The Princess Bride.
All right, so let's have it.
And so if Inigo Montoya had CKD, what would happen? And the answer is this. I want my Klotho back, you son of a bitch. So my favorite Mandy Patinkin and one of my favorite movies is Princess Bride, one of only 5 movies that I own, and 3 of them are Rob Reiner movies.
I love it.
I own 5 movies. The Princess Bride, directed by Rob Reiner, The American President, directed by Rob Reiner, and This Is Spinal Tap, directed by Rob Reiner.
I love
Those are 3 movies that I own.
Oh, he's great.
And so, if Inigo Montoya had CKD, I have no doubt that regardless of whichever hypothesis he favors, unless you're going to offer another one, Dread Pirate Roberts told him, I'll kill you tomorrow, get all your Klotho. And I believe this is the arbiter.
If you didn't have to have immunosuppression and you could have a perfectly matched, we could grow you a kidney from your own cells and install it in there to work with your other kidneys.
I think Barry Brenner has made a lot of accurate predictions. He predicted that he measured glomerular hemodynamics and talked about the badness of glomerular hypertension.
Right.
He talked about the high protein diet and how it would affect those glomerular hemodynamics, and that a low protein diet is going to be better on the kidney. And he predicted that your nephron endowment of how you're born.
Right.
And we showed that last time with the blood pressure. We showed that the age match controls the people who had less nephron number got hypertension and did worse. But if they have less nephron number, they have less Klotho.
Right.
Okay.
Right.
And he said, if you're getting a transplant, get the biggest kidney you can. So I think I think if a small person gets a big kidney,
that's a big dose of
there's no downside.
Right. No.
I think if a small person says we got a small person kidney for you and a large person kidney for you, if I was a small person, I'd say, give me the big kidney.
Yeah, and I guess that's my other question is that...
I mean, you want to be well endowed in some way.
If we got really good at giving... Well, I mean, there are things out there about, and I've seen this online when I was looking for some more about Klotho and I was reviewing that, where people are actually infusing, they're talking about infusing Klotho to actually treat renal disease. So, okay, you're stage 4. Well, if you give this Klotho infusions, we're going to get you up to stage 3.
Well, put it in a more extreme scenario. As we've said before, where's the place you most want to not lose your Klotho? In the ICU, because the ICU brings with it a high chance of death.
Right.
And we know that kidney disease in the ICU, AKI in the ICU, especially if you require dialysis, puts you in a very bad prognostic category, a lot of death. Mm-hmm. Those people have just lost their Klotho right when they needed it. So I think the first study I thought of when I saw Klotho come out was,
they lost their Klotho function quickly.
Yeah, who's going to do the study that shows what happens if you give Klotho back in severe AKI? And then, of course, the CKD study too. But if you lost it quickly and you give it back quickly, that's actually kind of cleaner. Okay, you had a low chance of death.
Right.
Then you landed in the ICU, and now you have a high chance of death. Then you landed in the ICU with AKI, you have a higher chance of death. Then you land in the ICU with AKI, and you need dialysis, the highest chance of death.
Right.
What happens when those people get Klotho? They acutely lost it. They acutely need it. And here's what
given it.
Right, and then and this happens, and this is before all that calcium. All that phosphate stuff happens.
Right.
They're not ossifying their vessels in the ICU.
It's early.
They're dying with still not ossified vessels. So
right.
I would want to know that. And that would help with this hypothesis, put together what we're talking about with the hypothesis. So I know what Inigo Montoya would do, I think. and I think the idea is Inigo Montoya would say, I want to be Paul Rudd. And so if we can get Mandy Patinkin, I'll tell you what, you work on Paul Rudd. I'll work on Mandy Patinkin, getting him to. We used to belong to the same synagogue in Chicago, so let's work on that. But I think in the end, what we tried to do in this talk is point out that before 1920s we didn't know anything. In the 20s and 30s with Fuller Albright, a lot of this stuff came into perspective with how calcium and phosphate and PTH, how the hormones were acting. We still didn't know how the parathyroid was doing it, but the calcium sensing receptor got cloned, FGF23 became available, and then we saw what happened to the accidental Klotho mice.
Right.
Klotho knockouts. And now that people in all sorts of different fields, including the neuroscience field, are saying Klotho, good for your brain.
Right.
I mean, you can't separate, it's hard to separate brain from cardiovascular disease, cerebral vascular disease. So again, what's good for brain is not having cerebral vascular disease. What's good for not having cerebral vascular disease is having good mineral metabolism. What's good for good mineral metabolism is Klotho, and not having kidney disease. So, I mean, we all have seen that dialysis patients have decreased cognition. Now, they have so many reasons to have it. They're sick, they got diabetes, they got high blood pressure.
The milieu is completely off.
We're changing we're shifting their fluids and changing their blood flow and blood pressure all these hours a week, and then they don't have Klotho.
Right.
I mean, these are not going to be the people that are going to be the best applicants for Mensa, because even if they were in Mensa, they've lost it.
Right.
Okay?
Right.
But the transplant patients, and I just read recently, I saw last week that I think I saw this on Twitter, that the person, I think there's a person in either England or France who's had a kidney transplant for 50 years.
That's amazing.
And that's before all the good, the improved drugs.
Right, exactly. He's on cyclosporin.
So I think there's a couple people. I mean, the longest I've ever, I have a patient who's in his early 90s.
Yeah.
Who got his sister's kidney. And he's had his kidney transplant for going on 40 years.
Yeah, I have a patient who's in that range, got his brother's kidney.
Yeah. But this guy with the 50-year kidney was a deceased donor.
Oh, it's amazing.
Which makes it even more amazing.
That's amazing.
And it was a deceased donor in the era before we had tacrolimus. So, maybe that kidney had a lot of Klotho.
Yeah.
We don't know.
There's still a lot to learn. There's a lot to understand.
I don't know what else we're going to talk about.
No, I think that's. Oh, you mean after this talk?
Because we're talking about life and death and everything.
Yeah, that was pretty much it. And aging and chronic kidney disease. We have to get to CKD.
Well, I want to see what. And we've touched on a lot of CKD.
Yeah, we've touched on a lot of CKD, but I think pulling CKD together may be helpful.
Yeah. Well, I'll have to go look at the Princess Bride and see what other questions.
Yeah, see what other things come up. Alan, great job once again. That was a super fun discussion, a great review of a complicated topic, and you really helped us understand things much better. So thank you.
Let's get Paul Rudd, Mandy.
Yes.